patient is foreigner and come to meet me in Thailand, and I test the father test positive, and the active piriformis positive, MRI negative. But if you look at the piriformis muscle and the sciatic nerve, you can see the piriformis muscle hypertrophy and the sciatic nerve on the left side hypertrophy as well. But fortunately, in this case, the EMG confirmed the incomplete mild degree of left sciatic nerve denervation. So I got the hard evidence to release the piriformis. This is one of my position. I can perform the lateral decubitus in prone position, also can do, and also in the supine as well. It depends on you prefer, right? In this case, I perform with the lateral decubitus, and this is the OR theater setting. And first, I mark the catheter first, and then put the needle, hit the catheter first, and then go to the piriformis fossa, confirm by C-arm, and put the dilator in. And after that, you put a scope and identify the piriformis tendon and release the piriformis, and then follow the sciatic nerve to make you clear, you have decompression the sciatic nerve. And this is the photo. And after that, put the drain. I would like to show the video. The first, I identify the catheter first, and then go deep down to the piriformis fossa, remove the soft tissue, and identify the tendon by internal rotation of the leg, and make the piriformis tight, and move the surgical field away from the sciatic nerve. And then you can see this is the combined tendon, right? A conjoined tendon, and then release the tendon. After release the piriformis tendon, go down to the interior capsule, and to see, for this case, the quadratus femoris also tight, so I release some part of the quadratus femoris. Okay, and then this is the sciatic nerve. You see the sciatic nerve is good right now. Try to mobilize the sciatic nerve. And this is the first case that I show you. MRI LSI is normal, but if you see the sciatic nerve and piriformis, you can see the not hypertrophy but hypertrophy and very tough. So I perform the piriformis release, and the day after, tomorrow, she pain from 7 to 1. She suffered from the pain for 3 years. Thank you for your attention.
Thank you very much. It's a nice presentation. And of course, there may be many questions for this subject. First of all, it's my question, please. When you start to do endoscopy for piriform, you send it before that for injection, like to pain management, how many times? Give a trial for injection.
Normally, the patient have treated in the pain clinic.
Yes.
Maybe the last case for 3 years. They have many kind of injection, many kind of pain modality, like the injection percutaneous under CT guide to the under ultrasound guide also perform.
Yeah, sure. And when you doing endoscopy, is it open the door to do for carpal tunnel syndrome? When you, if it is successful for piriform syndrome, it's also possible to do it for carpal tunnel syndrome. Can we use endoscopy for carpal tunnel syndrome also? Same philosophy.
What's the
May
carpal tunnel syndrome?
Yeah,
Oh, it's not allowed. I am hip and knee and spine, so I cannot perform this is the hand surgeon. And in our hospital also perform the endoscope release in carpal tunnel syndrome as well.
And
I need
my
to-
suggestion, I'm sorry.
Okay.
I suggest to reach to target point by using ultrasound guide. It's better than CR guide you to the sciatic nerve. So we can depend on ultrasound at the target to reach the target point. It's much easier and without any complication. Use ultrasound guide to reach to the target. It's my suggestion, simple suggestion.
Yeah.
Thank you very much.
Thank you.
I need to add more information about carpal tunnel syndrome because we are neurosurgeon. We have a professor from USA is using it for long time and have his own set. That's why it's not a recent concept. It's already used, but you have to have the tool to do it and experience too. Thank you.
Any question? Any more question?
No.
Thank you so much.
Thank you very much, Dr. Panpapit.
Okay, I'd like to call Professor Otamo from Thailand, and he will speak to us about extraforaminal disc herniation, a comparison of surgical technique between full endoscopic discectomy and UBE discectomy. Okay, see.
Okay, namaste. Good afternoon. Thank you for having me, and I'm honored to be here. Today, I would like to present about the extraforaminal disc herniation, a comparison of a surgical technique and between the full endoscopic and biportal endoscopic discectomy. Extraforaminal disc herniation occurs around 6 to 12% of all lumbar disc herniation. And according to the unique anatomy at this area, the surgical approach is different from that of intracanal lesion. Here, versatility is almost inevitable, and soft tissue damage often occurs. So modified Wilson approach hence was developed to reduce these problems. And by the way, these approaches are often associated with partial bone removal, and therefore increasing the risk of spinal instability. And Professor Cambin described the uniportal arthroscopic discectomy through the Cambin triangles. An indication to use the endoscopic discectomy technique have since changed. So many approaches were developed for foraminal and extraforaminal lesions. For transforaminal technique, needle insertion is around 7 to 10 centimeters lateral from the midline, and the angle of the needle is steeper than the conventional technique. So in this case, the full endoscopic lumbar discectomy was performed by the transforaminal technique. As described before, a needle insertion was about 8 centimeters lateral to midline, and the target to the junction between the SAP and the lower pedicle. And after that, sleeve and the endoscope was advanced to the target as shown in this picture. And first, we clean the soft tissue around the starting point of the SAP and the pedicle by the RF and identify the foramen. And beware of the bleeding from the branches of a radicular artery. And then gently move the sleeve and the scope to the cranial side, because where the nerve exit was not clear, and we don't want to cause the further injury. Then clear the foramen and identify the disc herniation area. And we open the annular with the ronger and the coagulator until the disc fragment was found, and remove all of the disc fragment with a punch, as shown in this video. And after that, we use annuloplasty, was done by coagulator. And finally, we confirm there is no more nerve root compression by checking its tension. Okay, so UBE or best technique use two portal. The key of UBE is to build a triangle and create a potential space at the target area. And distance between two portal is around 2 to 3 centimeters. For extraforaminal lesion, there are many initial target points depending on the lesions. The portal incision is usually 1 centimeter lateral to the target point. And UBE was done in this case with a paraspinal technique. According to the extraforaminal lesion, accessory approach was chosen to the target point. So first, we clean the soft tissue around the lower part of a transverse process and lateral of the isthmus and the SAP to identify the accessory process. And then drill the accessory process as and the lower part of the TP until the ligament was released from the bony structure. And be careful of bleeding from the branches of a radicular artery. And gently remove the ligament and soft tissue until the exiting nerve root was observed. Then identify the space between the SAP and exiting nerve root to find the disc herniation, and detach the disc fragment from the nerve root and remove it. Then the annuloplasty was done by the coagulator, and finally, the free exiting nerve root was observed. Okay, and comparing techniques between two approaches, full endoscope can be performed under the local anesthesia and general anesthesia, but UBE is usually performed under the GA. The target point of the full endoscope is a junction between the SAP and the lower pedicle, while the UBE has many targets depending on the disc level and lesion. And the disc herniation can easily observe in the full endoscope, whereas in the UBE technique, the exiting nerve root needs to be identified before the discectomy could be done. And due to its special instrument and unique approaches, so more learning curve is required for a full endoscope technique, while the UBE technique is similar as microsurgery. And although the full endoscope can directly remove this herniation, causing less harm to other structure and require a shorter operating time. But the nerve root injury can occur due to the needle insertion and sleeve movement. And according to the wider endoscopic view and more movement of the instrument, the UBE can manage the combined lesion properly. By the way, massive bleeding can occur due to the injury to the branches of radicular arteries, and retroperitoneal fluid collection can happen due to the improper management of in-outflow of the normal saline. So in conclusion, Wilson approach is still a gold standard for discectomy in extraforaminal disc herniation. And nowadays, endoscopic surgery has more role in management of a disc herniation. Full endoscopic transforaminal approach can directly handle this problem and is less invasive, while the UBE technique can give wider view and more degree of the movement, and similar to the microscopic surgery. However, both techniques can give good outcome as gold standard, and understanding both of them leads to the better decision and the patient outcome. Thank you very much for your kind attention.
Is there any question?
Any questions? Thank you, Dr. Utamo, for such a beautiful comparison and beautiful videos of doing the disc, removing the disc. And now we have can I call upon Dr. Prasad Patkankar? Dr. Prasad Patkankar. He will talk to us on algorithms for full endoscopic approach selection. We have seen so many approaches, so he will give us which approach when.
Yeah. So very good afternoon. Thank you so much, organizers, for the opportunity to present this work. Now, last 3 days, we have been seeing the various approaches. And for the beginners, it is very difficult to understand how to go about each approach and how to learn all the approach at one go. So probably masters definitely can do the surgery and then they can assess the MRI just based on their eyeballing and they can based on their experience. But if you see this MRI where there is a bilateral lateral recess stenosis, probably you can do the bilateral transforaminal approach for lateral recess decompression. Same time, with the help of PSLD, as we are saying LEULBD, you can do the bilateral lateral recess decompression. But how to think about it? Which approach would be a better approach for me? Or for that matter, particularly for the patient, which approach selection would be a better idea? So anytime when patient comes to you, probably he doesn't come with a dedicated only lateral recess stenosis or maybe only herniation. The patient always comes with a presentation of symptom that I have got a sciatica like pain. It may be L5 radiculopathy, it may be S1 radiculopathy. You need to understand what kind of lateral proper approach and what kind of facet orientation is there, so that your transforaminal axis or your interlaminar approach would do the better justice to that pathology. So if we consider, we have developed an objective algorithm for the beginners, I would say, so that they can assess the MRI findings and they can go about selection of their cases. So in this study, we included only the cases where there is a herniation and stenosis without any significant instability or scoliosis, or we even skipped those cases which were only discogenic back pain or internal disc derangement. So if we see, probably first we start with the clinical assessment. Once your assessment is very precisely localizing the particular dermatomal pattern, you go ahead with the MRI. I would suggest for all the beginners, one should always have cuts at the upper discal margin, lower discal margin, middle of the disc, middle of the vertebral body and middle of the pedicle. If you have got all those cuts, probably you will not miss on any pathology, may it be a superiorly migrated, extruded, sequestrated herniation, because they are sometimes missed if the cuts are taken only at the level of the disc. If we are looking at the upper discal margin, what you are actually looking at? So most important thing is you need to see these exiting nerve roots, which are the large exiting nerve roots, the dorsal root ganglia, which is seen. And the important pathology lying around this, maybe sometimes you will be seeing the blob of tissue, which is compressing dorsally. That can be the causative factor. Sometimes you may find a superiorly migrated herniations. Sometimes it may be a extraforaminal herniations. So your eyes should be trained towards looking at those upper discal margin cuts so that you can address your endoscope, or your particular endoscopic technique has to reach that target. So if we go to the other middle of the disc, what you are looking at is a traversing nerve root, which is the main which is getting compressed. May it be because of the facet, non-articular part of facet, or may it be the flavum. Similarly, if we go to the lower discal margin, they are the more common offending site, which is an entry zone for the traversing nerve root, and where you find the pathology that is compressing the traversing nerve root. So if we see the accessibility of all the endoscopic approach, your transforaminal approach is addressing this pathology. You may go up to this, that is a central herniation. But if you are looking at your interlaminar approach, which can take care of this ipsilateral pathology, same times you may have contralateral pathology you can address like this. So considering both the approaches, the principle of the full endoscopic selection is based on the facet orientation, where you tend to remove more amount of bone if you are not considering facet angle. And other thing what we realize, that any approach, whether it may be interlaminar or transforaminal, your approach should be at least having a 20 degree of facet angle with that particular approach. And then we consider whether the pathology is more anterior or more posterior, whether the migration is far migrated or near migrated. So we divide this based on this algorithm, which is called as FEMDIS algorithm. So we divide the motion segment into two equal half. It is right L4-5 FEMDIS, or it may be a left L4-5 FEMDIS. So what is FEMDIS? It is a facet angle. It is anterior compression, posterior compression, dorsal migration, inferior migration, and superior migration. So how do we define that which approach? Probably when we consider it is a more sagittally oriented facet, they are 0 to 25 degree. We tend to go for more transforaminal approach. When it is 26 to 45, we prefer transforaminal over interlaminar, because of the obvious reason that you don't want to violate the facet. F3 is when it is more coronally oriented facet. It is going between 46 to 65, when interlaminar is preferred over transforaminal. And F4 is when it is more coronally oriented, up to 90 degree, we can consider interlaminar. When it comes to anterior pathology or posterior pathology, if it is more of a herniation causing a stenotic or a root compression, probably you will consider as a standard central, paracentral, foraminal or extraforaminal. But when you are considering the posterior component, it can be a P1 component, which is a central flavum, may it be lateral recess. But more importantly, when you are targeting the foraminal part, it is whether the upper foramen is compressing the nerve root or the lower foramen. So based on this, we found that it is not, whenever we are getting an anterior pathology, it comes in a combination. It comes like a central, paracentral, A1, A2, it can be A2, A3. When it is a paracentral foraminal, it can be foraminal and extraforaminal. Similarly, if we consider posterior compression, it can be facet cyst, it can be a subluxated facet to some extent, it can be a flavum, which can cause compression. And sometimes there is a bilateral compression, as you can see the right side upper image, where you can see the hard osteophyte and the flavum, both are compressing the exiting nerve root. Otherwise, central canal is looking absolutely normal, and still patient is having severe neuralgic pain. So one need to train yourself and your mind and your eyes to see all those pathologies, so that you can address the pathology. May it be open surgery, may it be micro discectomy, but your target has to be very clear. So that's why this algorithm needs to be there in mind, whether you are doing any kind of surgery. But for full endoscopy, definitely it gives you a better idea about the approach selection. So when it comes to dorsal migration, we are dividing based on the line which is drawn at the articular surface of the SAP. And if the fragment is not crossing this line, it is a near migration. If the fragment is crossing this line or touching this line and it is a soft fragment, you can call it as a D far soft. And if it is hard fragment, central located, and it is crossing this line, it is a D far hard. So now inferior migration we graded based on if we divide the vertebral body into 3 equal half, And then we see the migration. So this is near, the second one is far migration, and third one is very far migration. Similarly, the superior way, if we divide the upper vertebral body into 3 equal half and see the migration, it is superior, near, far, or very far. So by and large, this becomes a complex kind of stuff if you see by and large. But what we made out of this is a FEMDIS calculator. So we made a calculator. If you just place your finding, MRI finding in that calculator, you immediately get the answer. This is your score. So you need not remember all those criteria. This is our in the background of that calculator, this is the data already fed, and you find based on this, if this is a calculator for your reference if you want. So with this QR code, you directly access to this and you just put your findings on the calculator and you get the score. And that's gap between the transforaminal to interlaminar approach. If it is 0 to 0.5, the surgeon's choice or a preference is acceptable. But if the gap is definitely more, going more towards transforaminal, approach which has got a higher score should be selected. Ideally, that would damage less, but you can still will be able to do a adequately nice decompression as much as possible. So as a sample case, how do we actually calculate? It is a central disc herniation. If we see the FEMDIS calculator, it is F2, it is A1 pathology, A2 pathology. Posteriorly, there is nothing which is compressing. There is a down migration, inferior migration, which is near, dorsal migration is near, and there is a near inferior migration, and superior migration is not there. So this gives you a score of 5 to 4.5. So probably both the things are acceptable because the score is just 0.5 difference. Here we have done, because the transforaminal score is more, we prefer transforaminal approach, and you can see the post-op MRI. Similarly, if this is a case where there is a coronally oriented facet F3, A1, A2, P2, posterior is paracentral, dorsally there is inferior migration, dorsal migration is near, inferior migration and superior migration is 0. The score is going more towards interlaminar. We did a PSLD that, and you can see the post-op MRI which can do the job. So in conclusion, the new surgical classification of causative compressive element needing decompression gives simpler universal nomenclature, and the classification guides to the best of available full endoscopic approach for the given pathology. So thank you so much for your patient hearing.
Thank you, Dr. Patkankar, for such an extensive, analytical, informative lecture. And coming to an algorithm, it will help a lot of us.
Thank you.
Yeah. Do you have this paper somewhere published?
Sir, this is under publication. It has
All
not
right. Thank you.
Okay. You are talking about single institution experience.
Yeah.
Am I right?
Yes.
Okay. How reliable this algorithm? Or you will make multi-centric?
We can make it multi-center, because now currently our fellows are also using this, and now we are doing a validation of this algorithm.
So how to be confident that your results will be good when we take this algorithm and apply it to our patients?
Yeah, because already we have done our this research is going on since last 4 years, and this publication has come now after the almost, this study itself has got 400 plus patients included in this, and we have done a prospective evaluation.
Okay, then you will manage it and follow up for how long? What's your plan? How long time will you follow up this patient?
No, this patients already there, many of them have got 1 year plus follow up. Many of them.
1 year.
Yeah.
Okay, thank you.
Any more questions? Then let's put our hand together and I call upon Dr. Lavkush Pandey, managing pain during spine endoscopy. Okay. So since Dr. Lavkush is not here, is the theater ready? Dr. Rohidas?
In 5 minutes, I'll be ready. Just 5 minutes.
Oh, in the meantime, can you tell us the story of the patient story, please? Can you tell us the case study? I would like request Dr. Mohinder Kaushal and Amit Tappa to take over the moderation of this the stendo surgery.
Yeah, Dr. Rohidas. I think all is set. And meantime, can someone tell us about the patient's clinical history, his radiology? Anyone in the theater who can this camera guy focus on the MR pictures and X-rays of a patient?
Madhav, tell the story, no? Take the mic.
Yeah.
Remove my mic.
So,
So this happens to be a 17-year-old. Am I audible in the hall?
Yeah, can be a
Yeah.
little louder.
Okay, so I'm going to narrate the story for you. This is a 17-year female who presented with a low backache radiating to the left lower leg for the last 1.5 months. Along with the pain, patient also had tingling in the left leg. And she had a history of a fall 7.5 months back. Apart from that, on the examination finding, there had been everything normal except, there was no weakness, no sensory loss. And then MRI.
what about her SLR?
So left SLR was 70 degree and otherwise right is okay. And if you see the MRI, there is at the level of L3-4, there is a cystic lesion intracanicularly just at the level of the pedicle, left side. So there was a compression of the L4 nerve root on the left side. Apart from that, there was a small disc bulge at L4-5, but then this is not that significant enough. There is no central canal stenosis because of that disc. There's a small disc bulge on the L4-5. So the pathology is localized at L3-4 disc on the left side at the level of the pedicle.
Is Dr. Andreas here? Will you be able to do this surgery through Dr. Andrea? Would you be able to do this surgery to your system? All right.
So, Dr. Rohidas, what are your final diagnoses and what are your operative plan?
We can't hear.
रोहिदास सर का थोड़ा वॉल्यूम बढ़ाएं.
She is young and this is post-traumatic. The hyperdense region is on the left side in the lateral braces. It is inferior to the disc space. And in one actual thing, we can see that it is connected to the.
What is your clinical diagnosis, doctor, looking at the MRI now?
Cystic disc.
Cyst.
Yeah, so this cyst.
Cyst of the cyst of the nerve sheath, or
no, it's a disc cyst. In young
this
patients, when it's a traumatic, the nucleus pulposus comes out like a
hyperintensity is the not totally degenerated disc. It is a disc rupture forming a cyst.
Okay.
Shall we start?
Tell out camera guy to come opposite to Dr. Rohidas to show his hands to us.
You are showing the Destandu system here.
Yes.
You have
Like
you now go directly to about the level, or you use your system.
Localized the level which is localizing pin.
Okay.
Third identifiable level from the sacrum.
Okay.
L3, 4. मुझे तो चाहिए like
Which side of the midline is your incision, left or right?
It is the symptoms are on the left side, the pathology is on the left side, so I
Okay.
am approaching from the left side. I have marked the midline. I'll be going something around 1 centimeter lateral to the midline.
Great. Have you infiltrated anything or?
Yeah. When I prepare the skin, after that, before putting the major ref, I inject 10 cc of glycogen.
Your picture is gone. Your picture is not there. Yeah. थोड़ा zoom कम करिए. Tell this camera guy. Yes.
Okay.
Good.
Yeah. So we'll go paramedian. Okay. The thin built patient. But the obese patient, what you have to do is
So level marking has been already done to cut short on time.
because
Okay.
yesterday it was shown how to localize and how to use the localizing bit. In obese patient, make the skin incision, and before cutting fascia, please confirm the midline again by palpating the spinous process. Otherwise, sometimes we have seen that people are going on the opposite side over the spinous process. Scissor. So this is the midline again, tip of the spinous process. Knife. Then I'll cut the fascia in paramedian fascia only. Same. Fascia is cut in paramedian, so that the closure of fascia becomes quite easy. Then I'll separate the muscle from the spinous process and the interspinous ligament. This step is very important. You have to separate it nicely. I'm palpating the L3 lamina. Lower down, I'm palpating the L4 lamina. There is an osteotome in the operating suction. Suction. No, it has to be paramedian. Then closure becomes quite easy. Hello? Okay. Then there is an osteotome inside the set. You can just do a subperiosteal dissection by this. But you have to be very careful while using this because sometimes it slips. The original osteotome in the store set is quite sharp, and there are chances that you will, in osteoporotic patients, you will damage the bone, and you can go inside the and damage the dura also. It has happened once or twice. These are the two muscle gauze pieces which I put. One is cranial, which is retracting the muscle. Other is caudal, which will go over the L4 lamina. Okay, so I have retracted the muscle with two gauze pieces. These are not techniques which are specific to endoscopy. These are the things which we have used in open surgery. Nothing else. Now the trocar is over the lamina. What? Now, when you put this outer tube, you should be able to see the lamina in the upper half and the interlaminar window in the caudal half of the outer tube. This is a smaller tube which I am using. This is called endospine, smart endospine. This is little smaller as usual to the usual endospine tube.
Why it's called smart?
It's a smaller one. The incision becomes 5 to 8 millimeters smaller than the usual one. Start it. Light बढ़ाओ. पूरा लाइट बढ़ाओ. अरे लाइट का क्या हो? हाँ है तो नहीं है. क्या हो गया? पकड़े. हाँ लाइट. क्या हो गया था? बंद करो अभी. Give me specs. शुरू करो. Yes. Give me specs. करना पड़ेगा. Cautery change करा. You are able to see 2D.
Yes.
Cautery change करा. वरच्या लाईट सगळ्या बंद करून टाका. सगळ्या ट्यूब लाईट्स पण माझ्या शेजारचे बंद करा. बस झालं का रे?
Rohidas.
Yeah.
PC here. Tell me the orient us at least.
Yeah.
Orient us. It is left approach L3, L4.
Just let me prepare the operative field and I'll orient it.
Okay.
In endoscopy, the monitor 12 o'clock is always midnight. 6 o'clock is always lateral. Only we have to think about cranial and caudal. Now it is a right-sided, left-sided approach. So on my left hand, that is 9 o'clock is always cranial. So this is the initial stage. You have to prepare everything. This is L4. This muscle piece has to caudal.
Clean the telescope.
So this is L3. This is L4. Give me this cursor.
Clean the lens.
Are you able to see?
Lens में drop आया ना? Clean that drop. Black spot.
What is the problem in 2D image?
No, no, it is very clear.
This question.
In the telescope, there is a dot, that is a black spot.
1 minute.
Clean that black spot.
Now
Maybe
this is
that is
L4.
the blood.
This is L4. I'm palpating with this forceps is L4.
Rohidas,
Yeah.
clean the telescope.
Okay.
Okay.
Now
कर रहा है.
it's okay now. Okay.
Yes, nice.
Now I'll orient you. Penfield. This is cranial.
Yes,
This is caudal.
yes,
This is midline.
nice.
Lateral. Correct?
Okay,
I'll
okay.
start with drill. Drill the pad good. Come here, drill the pad.
So could you show us the spinous process and the facet?
This is the spinolaminar junction.
Okay.
Very simple. Now you will be able to see the this is spinolaminar junction. Great.
Rohitas, don't you use saline while burying? The amount of heat it produces, eh?
You can observe I'm using it for 30 seconds or 45 seconds.
Then there's no
I'm
need.
cleaning my endoscope lens. Till that time, everything settles down. There is no need for irrigation. I'm not using it for 2, 3, 4 minutes continuously.
So 30 seconds, if you use, then fluid can be avoided.
I operate very few cases. I'm comfortable operating very few cases comfortably. I don't want to operate too many cases. Very simple. And remove the lamina till I detach the flap. This is now usual in all cases. Curate. I can use a curate to detach the flap. These are all routine instruments. Now here you can just zoom in and see. Okay. Need to remove a little bit of lamina more.
Is there an endpoint for removal here?
Till I detach the flavum from the lamina.
Okay.
This process. And just remove this outer layer of the flavum.
Hmm.
Okay.
You have removed the superficial layer.
The outer layer. Yes.
Yeah. Yes.
Second. Lock. Give it to you. This is the medial facet now. Okay. This process. This is L4. Got it. Got 3. Fill the soft tissue. This is L4. Cancer. I'll try to detach the flavum from L4. Okay. This is L4. Okay. I can zoom in and see what I have done. So I have detached the flavum from L4. Okay.
Yeah.
Yes.
Previously, in my book also I have mentioned that you remove the flavum from the cranial vertebra, then put a cottonoid, push the dura anteriorly, and then follow the flavum with 90 degrees. Nowadays, I do everything with 45 degrees, where I detach the flavum from all sides, and then I'll try to remove.
So you are not conservative on the flavum.
No. What I need is very good exposure and decompression. That is my aim.
What made you?
All our surgeries are for nerve root.
What made you change your mind that you detach now from caudal and flavum, not from cephalad, as you have mentioned in your book? Any advantage of doing this?
Any advantage of? Please repeat.
You detach the flavum from caudal side. Any advantage of doing this?
Both. So there are less chances that I'll injure dura.
Okay.
Correct?
But the anatomically the attachment is on the
Undersurface of superior lamina.
Superior undersurface.
So what you write in your book, you don't preach practically.
Yeah.
Now I have changed. Now I have changed.
Thank you. Thank you for saying it. I want.
You have to change as your experience goes.
Anyway, carry on. I don't want to make you nervous. You have been.
No. You have to change. Don't. After your experience, when I started this technique of removal of flavum, dural punctures are very less. Okay. Harrison.
She's a young girl. Probably can we preserve part of the flavum medially and just remove lateral half and reach the pathology and do the job and come out like a.
In the lateral basis.
Huh?
Now cyst is in the lateral recess, correct?
So
You have to see the lateral edge of the dura, or no?
yeah, so we can preserve the middle part of the phlegm. Only laterally we can remove and reach there. That's what I am trying to put across.
No.
You want to remove whole of phlegm. Hemiphlebectomy you want to do.
Yes.
Okay.
Benefit and back.
You have exposed a little margin of dura, still you have to do
Not yet.
bone work,
Not
little more bone work. Huh?
I need more bone
Yeah.
because I should be able to retract it very easily.
Okay.
You see,
Yeah, we can see fat and nice glistening dura. Yeah.
always zoom in, see what you have done, come up and again work. 2 mm patient.
So I think in dry endoscopy, moment he has put in a patty, you can see there is a clear demarcation between the phlegm and the dural and neural structure, you can say. And same thing does fluid. When you switch over to fluid, in fluid endoscopic, same differentiation demarcation you can appreciate. So here in dry endoscopy, dura is a very, very important tool.
Yeah. Only the fluid washes out the byproducts of what you are doing.
So, and here the principle is try to expose up to the lateral margin of the dura so that you can comfortably retract the dura. Doing retraction, if you don't expose up to the lateral margin, can cause some dural injury. So that's important. That's why he is taking extra time to expose the lateral margin of the dura.
I should be careful in each and every case.
Yeah, every case is a challenge in itself.
Now I'm using 2 mm crescent punch. 2 mm 45. Nerve hook. 47.
Roses, can you clean the scope once again? There is some fogging. So we are not, although picture quality is good, we want to make it see it better.
Okay.
Yeah, much better. Thank you.
I'll go a little bit quadrant. Nerve hook.
I think
Crescent.
if you remove the patty and then try to retract dura, will that be easy?
Repeat.
If you take out the patty and then mobilize the dura, I mean, patty is pressing the dura, so dural mobility is restricted.
I'll replace it, no problem. Let me see the lateral edge of the dura first and then hook.
Yeah.
This is the cyst. You are able to see this is the bluish thing.
Yeah.
1 minute. Yes. Good. Very simple. The lateral edge of the dura, and underneath you are able to see underneath my pen field the white thing.
Yeah.
Is the nerve root
It is at-
adhered?
It is at 6 o'clock.
Yeah.
Yes. Now you're able to see the lateral edge of the dura. 1 minute.
Yeah.
Yeah.
Yes.
Yeah.
Yeah. I'll put a cranial patty first. It will retract the dura and the shoulder medial. How to put this cotonoid you should learn from your EMT colleague. They are very well versed with this. In cynoscopy, they use endoscope in one hand. Yes. You are able to see the cyst?
Yes.
Yeah.
Yes, this is the cyst. Now I have to follow this down so that I will be able to 2 mm.
Dr. Redas, is the nerve adhered to the cyst or what is
It
it?
has to be adherent because it's a young girl.
You have to mobilize it very carefully then. Huh?
That's why I'm very careful.
Sorry, can I ask a question?
Yes,
Yeah.
please go ahead.
I wonder what kind of machine do you use for hemostasis? Can you show us just what kind of machine? I think.
What kind of
We are using
bipolar?
bipolar
machine?
cautery.
Okay, okay.
Huh.
Bipolar cautery is
Like
coming in
open surgery?
with the set.
That is a endoscopic bipolar coterie. That is specially meant to use with this tube. That is not an open bipolar coterie.
Yes. Now this is the shoulder of the root, you see,
Yes.
at
Face.
5 o'clock.
Yes.
And this is the cyst. Now what I will do, I will put a small cotonoid here, which will retract the root medially. Correct?
Yeah.
Small.
Will you like to use nerve root retractor also at this stage, or you will?
Let's see, I'll try to use it just to have a good exposure.
Yeah, that will show us cyst in a much better way.
If someone wants to use, because in endoscopy, what happens, the opposite sided dissection is quite easy. If someone wants to use opposite side approach, like this is
Approach from the
left-sided,
opposite side.
so go from the opposite side, that is also okay. Now you are able to see the anatomy clearly.
Yes.
Yeah, that's why she was in hook. Lot of pain. Now this is the lateral edge of the dura.
Yeah.
Correct.
This is some adhesions. Yeah, yeah.
This is to be separated. Correct.
Yeah. Nice.
I'm retracting the root. And this is
Sorry, one more question.
Yes. Go ahead.
If you need to nerve retractor, how can hold it?
Yeah.
This
This
is-
is.
how to use
this
the-
is-
Rohidas, show us a demo of nerve retractor and tell that guy to show us outside picture also. Once you put in the, show us the endoscopic picture and tell that guy to show us outside picture also.
first
Cameraman.
show this outside picture.
Outside picture enlarge karo.
And show us a slot for nerve root
Make
retractor.
outside picture full screen.
Outside picture enlarge
Now
करना
this is the nerve root retractor.
और inside picture छोटा करना.
I am retracting the nerve root with the nerve root retractor. Got
Yes.
it?
There is a slot for the nerve root in that working insert itself.
Got it?
So outside picture, if you see, Rohidas, point on the nerve root detector. Yes, there.
The nerve root retractor.
Yeah.
This is the endoscopic channel. This is the suction channel. लगाएंगे.
Okay.
Yeah, that's better now.
Oh, very
Correct?
nice. Thank you.
Yeah, that's great.
This is the nerve root retractor.
Yeah.
Nice. Camera guy has understood
Suction.
our requirement. Yeah.
Now what I'll do.
Very good. Very good. Yeah.
Now this is the cyst. I have opened it.
Okay. Now
So,
inside picture बड़ा कर दीजिए.
Come back to endoscopic picture now. Enlarge endoscopic picture. Yes.
Not like this.
Yes. Puncture the cyst.
As before.
This is the bipolar.
Correct. Now outside picture smaller. Yes.
Okay.
What is your plan? To remove the cyst in toto or puncture?
How 10-50. आपल्याकडे छोटी सीझर आहे का? ठीक आहे.
It gives a look of a even big epidural vein, as if it is an epidural vein. Rohit, this is a vein or still it is a cyst? You have punctured the cyst.
Blue.
It's bipolar. So coming back again to the doctors from Argentina, Maris and Andrea, you think laser surgery would have been better here? Loudly, everybody should hear. You didn't want to give her a scar on the back.
Thank you. This was a very beautiful dissection, I have to say. In this case, especially because the girl is a young girl,
Yes.
we always do a epidural first. And we always give it a try. I think it is a good candidate for epidural. And it takes less time. You don't have to take ligament or anything because she's young.
Yeah.
So I would have started with epidural, but you have to use the technique that you know. That is the best technique.
But when the nerve is so much adhered to the cyst, how easy it is.
Very easy.
Very easy. Huh?
Yes.
Dr. Arvind, remember, huh? New technology from Argentina, from the ends of the earth. Laser beam. Any likelihood of differential diagnosis here, Dr. Arvind? Differential diagnosis?
Generally, such a cyst, I've not seen the MRI, I've just arrived. So such a cyst is either a cyst, regular synovial cyst coming from the flavum or the facet joint. It could be a discal cyst, and very rarely it could be a perineural cyst.
Perineural cyst, huh?
Yes.
Perineural all along the nerve like this?
Yes, yes.
And
It's
adhered?
usually adherent and bluish.
Okay. You can aspirate them?
I mean, they just flatten. Once you pierce your nerve hook in it, they're just empty.
All right. Thank you. It appears too fleshy for a cyst. No?
I haven't seen the MRI. So
Yeah. On the picture here.
I'm retracting the nerve root and the okay.
Look, some granulation also.
There is a wall also. What is benefit?
it's a cystic degeneration of the
This is
annulus.
wall. Okay. Yeah.
Yeah.
18 साल की लड़की अरविंद 18 साल की ट्रॉमा हुआ 2 साल की है
Everyone gives history of trauma.
Connection inside the disc.
सेक्शन डालो यार so he has probably done it now.
They have scoliosis, they'll give history of trauma.
This is the connection inside the disc. Okay. This is inside of the disc. Okay. Give me 2 mm something.
Any plan of suturing the annulus?
I'll go inside.
Or will you like to go inside also?
Yes, now this is the disc, correct?
Huh?
This is the disc.
Would you send this material for biopsy?
Yes, I always send each and every disc for biopsy.
How often you find different tissue?
No, I just, this is for the medical legal purpose.
Okay.
My pathologist mentions the weight of the disc tissue I have removed. So if the patient comes to you.
Sometimes if you have your own pathology lab,
This was not removed.
it makes sense. So if you're doing 3 discectomies a day, so it's about 25 in a month, so 75 biopsies. It makes sense.
But how often you get a different diagnosis?
Yeah, that's what.
No, what I'm saying is how often?
It's repeatedly shown in papers not to send a discectomy material for histopathology.
All right.
No, but Arvind, this has a medical legal importance.
No, it hardly has any
Other
medical.
thing is that
What are you saying? You say you
second
have
MBBS
recorded a video, you send a video.
anything
What all you want?
From the body,
You have MRI evidence, you've done a discectomy, you're an experienced surgeon. Repeatedly, it's been knocked down, you know, in the literature.
Huh?
Huh?
In second MBBS, we have learned that anything you are removing from the body, you have to send it for pathology.
He is doing it.
Yeah.
So when you're going to stop?
Till the tension on the nerve is free.
You need very good disposal to remove such type of things. And this is 2 years old. There are chances that you have a recurrent afterwards. Yes, coming out. You can see.
Because
Then go to
Some more building a hook around.
Amit.
Yes, I'm here. I'm watching you.
लगा अभी कुछ आपने बोला.
So how much disc you want to remove from inside?
Let's see.
Okay, okay.
He is doing a generous enlotment.
Okay, Dr. Rohidas, thank you for a lovely exposition and exhibition of your skills and the cyst decompression. We go for our didactic lecture program. Thank you very much. Please give him a big hand.
Any comment or any question from the house to Dr. Rohidas?
Before closing, I'll just take 1 minute up. I'll just show you the amount of PDC I have removed. Now I'll remove the disc, I'll irrigate the cavity, I'll go inside the disc space with endoscope and reconfirm that I have not left anything inside.
We call upon Dr. Paras Banka of the Department of Orthopedics at Holy Spirit Hospital to give a talk on cervical UB. He is the dynamo behind organizing this conference.
Seven doctors are coming, sir. 0 to 5 marks in each category.
Good afternoon, everyone. I will be presenting my talk on cervical UB. The indications are for which we mostly use a paracentral disc herniation, disc osteophytic process on posternal corners causing outlet narrowing of nerve roots, which may be used for single or multiple levels. The advantage of cervical UB, it's a motion preserving surgery with extremely low likelihood of causing adjacent disc diseases. Unlike the posterior scoffing approach, it is not associated with any scar tenderness or a significant scar tenderness. Coming to the landmarks, the uncinate process is the identification, it's a key landmark. It defines the nethermost extent of the disc complex. All paracentral herniations are occurring at this point, including the disc osteophytes complex. So explanation of the exiting nerve root is natural to the uncinate process. So this provides us with the most feasible landmark to land our instrument. And canal entry is safe as safe as you are natural to the central myelin. The patient positioning, we keep the neck parallel to the floor. We can take the shoulders behind and tape it to the body, and we strap the patient to the table. So this parallel positioning of the neck keeps an advantage of working with both the portals, scoping and working portals, and the hand remains in an optimum position. The skin markings, I can stress the importance of putting the first midline mark, that's the 9-1. It helps to define the rotatory alignment of the patient. The 9-2 is the outer pedicular 9, or as some people call it, Latin mass 9. 9-3 is 1 centimeter outside the 9-2, from which we can start targeting our instruments. 9-4 is the scopic portion, starts as the upper border of the same vertebral body. 9-5 is the for the working portion. We start from the lateral lower border of the lower border of the lower vertebral body, not body, the lateral mass. And we should keep in mind that to keep the both these points 3 centimeter apart, so there is no clashing of the instruments. It is always recommended to check a lateral view to see whether we are in the correct level or not. So this is the steps. First we mark the midline, then the scopic portion, then triangulation of the both the scopic and working portion near the V spot. And this is the instruments. We normally use a 70-degree RF probe with this. This is one of the intraoperative video. This is the pedicle. This is the root. I'm standing on the left side of the patient. That's the disc I'm taking out through the axilla. There's some central flavectomy I'm doing after taking out the disc. Yeah. Before closure, we put a drain under vision so that there is no hematoma, epidural hematoma. This is second video. It's we're working from the. Yeah. So this is the positioning. You can see the entry from the axilla into the disc. It's case 2. We're working from the right side of the patient. That's the disc we are targeting. We are going through the shoulder. That's the root. Yes. it's the immediate post-operative scan we have done. You can see the drain and the air bubble, and that's the area of fluid. With hard disc osteophyte complex, sometimes deroofing is only sufficient to get the patient relief of symptoms. Thank you.
Dr. Paras for a very informative lecture. Any questions? Okay. If there are no questions, can we go to the next session? Dr. Hwa of South Korea. He will talk to us on endoscopic. External.
Good afternoon, ladies and gentlemen. Thank you very much again, Dr. Malcolm. Okay. It's my honor to be here, and I'm thrilled. I'm thrilled with the great enthusiasm for endoscopic spine surgery. So today my topic is endoscopic. I call it X-TLIP for large cage. I came from South Korea, and now I'm working in Al College Hospital, UAE. There are many surgical approaches for lumbar interbody fusion, as you know, lip or lip, X-lip, and T-lip and P-lip surgery. Goal of spine surgery, I think, decompression of pathology region. We have to get bone-to-bone fusion, and if possible, restoration of spinal balance. For better spinal fusion, we need the precise and general and the preparation, and if possible, we have to use large interbody spacer. And also, we have to get proper cage position for balance. Sometimes we can use bone materials, orthobone, DBM, BMP, I factor, and other things. So whenever I'm doing endoscopic spine surgery, I feel some disadvantages. Footprint is too small, and lordosis correction is not, the correction is limited. So endoprep preparation is incomplete. We can see the endoprep preparation through the endoscopic view, but I think endoprep preparation is different, I think. So for good coronal and sagittal balance, I think cage size and cage position are very important. So let's look at the cage size. I think the bigger, the better. Tilly cage, the width is 11 and 13 millimeter, and length is 20, 32, or 38. X-lip or lip cage is width is 18 and 20, 22 millimeter. Length is 40, 45, and 50 millimeter. Also, I reviewed the cage position. 2009, Dr. Labush reported this. Center of endoplate is the weakest part. So that is post-operative picture is I did endoscopic T-lip surgery. Footprint cage, footprint is too small. So I changed it, use cage, oblique cage, but still small. But next case, I used the only cage. Not enough compared to X-lip, but better. And cage position in the coronal view should be lie from pedicle at least, and in the sagittal view, the center of a cage should be anterior part of a spine. So among this surgery, I think for the better fusion and correction, I think olive surgery is the best, I think. So I tried several cases of olive surgery, but I feel this kind of disadvantages, vascular injury, and sometimes it is disastrous. We cannot, as for spine surgeons, we cannot handle that kind of thing. So we have to call a vascular surgeon. So sympathetic chain injury and urinary tract peritoneal injury, and not so easy technique for ordinary spine surgeon, especially in the level of L5S1. Also, only indirect posterior decompression. If you want to direct posterior decompression, we have to change position. We have to do posterior surgery again. Also, we cannot use autobone, just we can use artificial bone. For posterior decompression, so we need to change position. It takes time. Others, high BMI, especially high BMI patients, previously had abdominal surgery or like that kind of patient, we cannot approach anteriorly. So I think if you are doing during the TLIP surgery, because the TLIP procedure is familiar to spine surgeon. So if we can put a large cage, like a Ollie cage or an X-Lee cage, is the best procedure, I think. So I reviewed the Cambridge triangle. So this is 2016. Dr. Reed reported like this. L45 level, the base is 18, L34 17, L23 is 13. So I removed facet joint totally, and I made a corridor. I call it, I extended length of extended Cambridge triangle after removal of facet joint. So I think L34 level at least 17 more larger, and L45 18 more if you remove the facet joint completely. L5S1, fortunately, the facet joint is very wide. The width is over 20 millimeter. So I can use, I think I can use Ollie cage, the size 18, 20, 22 millimeter. So I checked the pre-operatively, check in MRI, the length of extended Cambridge triangle, roughly, and L45 level over 18. L5S level over 18 and sometimes 20, 25. So I convinced. So this is a picture of endoscopic surgery. I checked the length, at least 20 millimeter. So I convinced I can put a large cage. So I removed the I did the total prostatectomy. So I used the same Ollie cage. I used Ollie cage and anterior and transverse line of cage and under endoscopic control. So I call it between TLIP and XLIP, I call it XTLIP. This video made by my junior doctor. This is all about of XTLIP surgery. So first, yeah, with cage guide, we put a cage and anterior cage position, and then percutaneous pedicle fixation. But percutaneous pedicle fixation is the same as what is surgery. Okay. Okay. This is postoperative wound. Sometimes I make another one incision for cage, but I think that already we know the size of incision is not that important, I think. So indication of XTLIP is the same as TLIP surgery. I show the cases. 65-year-old male patient, a low back pain and left leg radiating pain. Already he did 6 months before endoscopic decompression surgery, but failed. In pre-operative MRI in the L5S level, we can see the lateral recess stenosis and foraminal stenosis. So I did a transforaminal approach. This is a picture of end preparation. You can see the good preparation of end plate. But I don't think it's the best way to preparation. And this is autobahn. We get enough autobahn to pack all the interbody space. And this is video L5S1. You can see the L5 exiting the root, and already I removed facet joint completely. So this space, we have to expose the total entire Cambridge triangle perfectly. So procedure is the same as TLIP surgery. So in this case, there is no instability. We cannot explore in the medial part. We cannot see the transversing nerve root. This is a shaver, and we can use a shaver, and with the shaver we can remove the disc fragment. And then this is only case. We don't need to have to track the transversing nerve root. Just to put a only cage and putting the cage into the interbody space. Yeah. And this is a post-operative X-ray. Cage is from pedicle to pedicle, as cage position is very good and lordosis is very good. So this is post-operative MRI. You can see the cage positioned well in the L5S1 interbody space and the well decompressed state around the nerve root area. The next case is 75-year-old female patient. Lower back pain is left leg radiating pain. Grade 1 spondylolisthesis L4-5. And this is post-operative MRI. We can put a large only cage safely. And this is video. I did the paramedian approach because in case of spondylolisthesis case, I recommend the paramedian approach because I have to decompress the contralateral part. I have to see the contralateral part in the root, and I need some reduction. So I recommend the unilateral SWAP2 osteotomy. I recommend. If possible, I have to decompress. I have to break the other contralateral side facet joint 2 for reduction of spondylolisthesis. But in this case, I think there is no need to destroy the contralateral part facet joint because just the position we can get a reduction. So after retraction the nerve root, this is trial. You can see the 18, 45, 18, 6 degree. This is only cage trial. You can trial first. So we can reach a bit. This is cage guide. Through the cage guide, we can put the only cage, 18 millimeter, 45 millimeter, 6 degree, safely without nerve root damage. And then this is, I call it posterior orthogonal maneuver, cage position, anterior and laterally. Anterior and transversely, sorry. Okay, this is the final view. So next case is 75-year-old female patient, lower back pain, right leg radiating pain. Unfortunately, she has a schwannoma, L4-5, and spondylolisthesis. So in this case, I did a microscopic removal, and then I put a only cage through the posterior approach. And this is the picture of schwannoma. And next case is 76-year-old female patient, foraminal stenosis L2-3 and also spine fracture. And I did, because L2-3 level is length of extended LEK is small, so I cannot use a large only cage. But L3-4 level, I can use only cage. So L3-4 level, I put a only cage, and 2-3 level, I put the ordinary TLIP cage. So we can correct lordosis, kyphosis better. And next case is a 52-year-old male patient, recurred herniated disc, L5S and Y side. Actually, I did this case in the UAE first case, Abu Dhabi area. He is high BMI patient. So endoscopic surgery is, I think, the good advantage for high BMI patient. This kind of high BMI patient, if you open surgery, doing open surgery, the surgical field is very deep and we cannot get a operation view very well, but using an endoscope is very nice. So only 18 millimeter and 10 millimeter and 45 lengths and 6 degree. I put this cage into the L5S1 safely without nerve root damage. So we collected and we reviewed the data, and mean ODI is good, and discal space height is increased. The segmental lordosis increased. Also, lumbar lordosis increased. Okay. Surgical tips: I recommend at least unilateral septal osteotomy. Unilateral osteotomy. We cannot do the rear septal osteotomy. And anterior and transverse lying of a cage is important. So if possible, anterior restriction and posterior contraction. So I want to follow this rule, PILL mismatch, less than 90 degree, SBA should be 5 centimeter, and pelvic tilt should be 25 degree. So advantage of EXT lip, I think central and contralateral decompression is possible, and good for high BMI patient. And we can get better coronal and sagittal balance. Maybe proper high fusion rate and low subsidence rate. We are collecting data now, and already we did this surgery for 2 years. We are collecting data, and maybe less multifidus muscle injury, and less nerve root retraction, and we can see the visualization of the disc preparation is very good, and we can avoid the vital organ injury. And also, this is a spine surgeon friendly procedure. No need to back up vascular surgeon, especially in the L5S1 level. I think better than the Olive and Alip surgery. Complications, same as of TLIP surgery, but not easy technique. We always worry about nerve root injury and sacral injury. Yeah, this disadvantage, technically demanding, not easy. Sometimes dural injury happened. Relative contraindication. Some brave Korean doctors are doing this kind of surgery, multiple level and upper level, but I don't recommend. So above L2-3 level, I don't recommend. And sometimes L4-5 level, LK length of extended cambridge triangle less than 15 millimeter. I don't recommend, just to use TLIP cage. So I don't recommend also multiple level. 3 level, we can do it, but it takes long time. I don't want. And also, over than 15 degree lordosis correction is needed. I don't recommend. Just to do the scoliosis surgeons can do it. So present, since 2019, December 2012, I did the first case in Korea, and more than 10 hospitals in Korea, but now 200 cases maybe. So I and Dr. He published the article 2021 February, and 2002 also I published this article about this technique. So it's a possible mission. We can use a larger leakage through the posterior approach. Yeah, EXT procedure provides larger interbody fusion bed and spacer compared to those of TLIP surgery. I think bigger cages would be better, but still further long-term studies is required. Thank you for your attention.
Thank you, Dr. Ho. Got a wonderful lecture. Dr. Rudolph, please moderate. You ask some questions.
I'm Kishan. Nice presentation. Good. Because of spinal stenosis, big cause of spinal stenosis is due to lateral recess compression. So traversing route compressed in lateral recess. So I think it is difficult to see bilateral lateral recess. And do have a decompression lateral recess area. What do you think about that?
So if we have a lateral recess stenosis, if there is a need to fusion surgery, just the elevation of interbody space will cover that, I think. Just in case of just interbody space is not small, not compressed state, we have to decompress contralateral part. Okay, so we can undercutting of a spinous process, and so we can see the contralateral part easily.
I think lateral recess needed to direct decompression.
Yeah, but so most of the case of spondylolisthesis case, the patients who need fusion surgery don't need to remove the contralateral part, the lateral recess. Just I think elevation of compressed discal space will be fine, I think. Yes.
I have a question for you and actually everybody else. When you're doing an indirect decompression, just by putting the implant in the disc space to elevate the cephalad-vertebral body and obtain correction of the slip, how often do you think that you obtain relief of the spinal stenosis just by putting the implant in and doing all of that without having to actually do a decompression?
Okay, good question. So before insert a cage, sometimes you use this interbody spacer. Sometimes there is an instrument for interbody spacer, and usually I use a trier. First start 8 millimeter and 9, 6, 9, 10, 11, 12. We can put a serially. We can use a larger trier. Okay, so we can elevate collapsed interbody space. So after elevating the interbody space, and we can put a cage.
Actually, the question is, how often do you get relief of the neurologic symptoms just by doing an indirect decompression?
So I don't believe it's indirect decompression actually. So I don't believe. Yeah, I don't have any data.
Just tell that I have done around 250 OLIF cages. 250 patients, all by indirect decompression. No direct decompression. I have only one case which I had to revise. And I am a firm believer that you don't require any of these decompressions, what is being done. If you can put a larger cage, indirect decompression works till grade 3 or Shiza's grade 3, and that we have already published in our results of these.
Even if there is degenerative facial arthrosis?
Even in facetal arthrosis, even in Shiza's grade 3 type of stenosis.
I would have to
find this.
I would agree. I've only had
you may find this in this forum that I'm talking about, but this is what the fact is.
I would agree. When I do an indirect decompression, I've had to take back maybe 2 to 5% of the time to actually have to do a decompression.
Let's ask Dr. Arvind Kulkarni, who must be having the major series.
I don't do OLIFs. I do missed lifts, and I always do a ipsy contra decompression. So my also other contention is over a period of time that patient might develop subsidence, that patient might develop loosening because of osteoporosis. That can cause some degree of mechanical instability and cause pain. That is my belief. ESD is another issue altogether, but that particular segment which I'm addressing, I think that should be addressed well.
So we are going to publish a 2-year MRI study of OLIF of 40 patients, immediate post-op MRI and 2 years post-op MRI. And you cannot see a recurrence, but actually you can see a remodeling of the whole canal. There is a decompression and remodeling of the whole canal. So as the time passes, actually your decompression increases rather than losing the compression.
This is what Dr. Atul Goel said day for yesterday.
I'm not like an Atul Goel, sir, but
All right, good.
but I'm a firm believer of that, at least in degenerative spine.
Yeah.
Lumbar spine, not in cervical like Dr. Atul Goel.
Okay.
Sorry for.
All right. If we go back, thank you very much.
Thank you.
We call Dr. Zhang for his talk on lumbosacral interbody fusion.
Dr. Sobong with the lumbar sacral interbody fusion.
Yeah,
Using bipolar endoscopic technique and parenting with the spondylolisthesis.
Thank you, sir. This is my first visit to India, but I am getting comfortable more and more. I'd like to talk about today's biportal endoscopic interbody fusion in lumbar spondylolisthesis. And biportal endoscopic surgery has a lot of advantages below. Right, one is 3-level interbody fusion by biportal technique. Lumbar interbody fusion, usually I take 80 minutes. I think surgical time is so important. I think this video is the medial prostatectomy and remove the bone fragment, preparation disc space, and the cage insertion. Sometimes contralateral decompression, perform the contralateral decompression. Left one is degenerative spondylolisthesis. Right one is post-operative X-ray. Hemoglobin level was decreased from 13.4 to 12.3. Until last year, I used the arthroscopic probe starting the laminectomy. But since last year, I just only use chisel and punch to harvest allowable local bone to bone graft. Left one is longitudinal cut. Middle one is transverse cut and achieve the laminectomy. Middle lower picture is actual photo. Longitudinal cut, chisel with chisel, and the transverse cutting the lamina. Remove the bone, strut bone, and you can see the ligament flavum and the inferior articular process removal. Remove the flavum and disc space preparation. Change the switch left to right side. And curating and remove the disc preparation. Limbing, we disc space completely disc preparation. And I strut bone put the disc space and cage insertion. Okay, next. Before inserting the cage, we have to need complete end plate preparation, right one, and picture below local bone and the strut bone from the lamina. The local bone and the BMD discus the discus into the discus space with a funnel. I use 30 degrees scope. First is 0 degrees scope. You can see the narrow view. And this is 30 degrees scope. You can see the contralateral recess. 2019 to 2021, I 212 segment. Now it maybe 250 segment. In terms of surgical technique, two entry points are located above each pedicle, and the distance between the viewing portal and working portal is about 4 centimeters. Right one is a scar. Middle one is low line is fusion. Upper line is discectomy or decompression. Right in the right region, we standing on the right side of the patient, and we must grip distal or working portal with the left hand. Right one is you need to use the proximal portal. Insert casing. When insert casing, we need to proximal portal because of step over from spondylolisthesis. This is took a video for your better understanding. Remove the laminectomy and the disc preparation and the medial versatility. And sometimes we want to use BKG. We cut the top of the superior articular process. When the inserting KG, be careful of level extending root in spondylolisthesis. Left one is L3 extending root, and upper is traversing L4 root. After insert KG. This video is a short clip. Change the insert the KG, 2-level KG is L45. When we perform the biportal endoscopic surgery in spondylolisthesis, there are several things to be careful for. Dural adhesion. Sometimes ligament problem and dura is stuck together, especially lytic spondylolisthesis. So tear easily when removing the ligament flap. And the exiting root is close to the disc space. So when inserting the KG, be careful of the exiting root. And degenerative spondylosis always have facet hypertrophy. So we have confused. We are confused from different from normal anatomy. 54 male patient is spondylolisthesis and disc space height narrow. So right one is post-operative X-ray. This one is post-operative. For 51 female patient, you can I show the change the portal. Medial facetectomy, remove the bone fragment, left walking, cage the initial is right walking, and inserting the cage is left walking. 96 female patient is spondylolisthesis. In spondylolisthesis is when removing the ligament flavum occurred to tear. Remove the ligament flavum and tear dura. So big gap. So I stitch up directly 7-point general nylon and insert the cage and remnant dural tear. After insert the cage, okay, suture again. Okay. Good. This is really be careful for exiting node. Yeah, this is exiting node, so is starting the cage. Be careful. Okay. In revision cases, we can do biportal and interbody fusion easily. This is right one is a 2-level interbody fusion case. Okay. This surgery would be a good surgical technique for the lumbar interbody fusion. Thank you.
Thank you very much, Dr. Jung, for the excellent exposition. Any question for the doctor?
Yeah, I have a question.
Yeah.
Thank you for your excellent presentation.
Yeah.
Do you using the lordotic cages?
I use at present I use Tilly cage. Yeah, but I as I said earlier, I strut bone and from lamina and 2 or 3 fragment, and before inserting the cage, I put the strut bone into the discal space.
Okay, but means that the lordotic cages.
Lordotic cage, I don't use, but I am developing new cage for biportal interbody fusion.
Thank you.
Yeah.
Dr. Malcolm, do you have any question?
No. Thank you. Thank you. Wonderful talk, sir. Thank you. Brilliant.
Thank you.
Dr. Monchu? Dr. Monchu? Dr. Monchu coming first time to India from Turkey. Give her a big hand. And she's going to talk to us about the role of UB in this generation of the lumbar spine.
I'm so excited. Hi, dear colleagues. My name is Çiğdem Mumcu. I am a neurosurgeon from Turkey. Before my speech, I would like to thank to dear Professor Malcolm Pestonji to invite me this amazing congress. Today, I'm going to talk about the role of UB in this degeneration of the lumbar spine. We all know that minimally invasive spine surgery is increasing in use and popularity with both patients as well as surgeons. Research as well as clinical practice has shown that minimal invasive surgery is both safe and effective. Smaller incisions and less soft tissue damage lead to improved healing and faster recovery. Minimally invasive spine surgery has evolved over the years. It went from larger incisions with mini open techniques and expandable retractors and loop magnification to fixed tubes and microscopic illumination and magnification, and now using percutaneous incisions for endoscopic techniques. Endoscopic spine surgery more accepted Asia and Europe, but it is spreading all over the world. Endoscopic spine surgery consists of two main techniques. Uniportal, we know that uniportal technique is a single portal combined using and working channel as seen the picture where the surgeon is holding both camera and surgical instruments on the surgical field. Biportal technique has a viewing channel and working channel separately. This is actually advanced technique and popularized. UB is very different from the uniportal techniques. Biportal spine and spinal endoscopy has consisting of two separate portal, which is endoscopic portal and working portal, and this portal system allows us decoupling of the endoscope with the surgical instruments. And this is important because we are no longer limited by what we can see in front of us in terms of the uniportal technique. We are using arthroscopic equipment with standard lumbar discectomy instruments, which are found in every hospital in surgery center. This leads to reduce the cost. Also, it allows greater flexibility and enhanced visualization. We can view different angles with using 0 or 30 degrees camera that allows us more accurate angles of visualization of the surgical anatomy. And increased surgical versatility so that we can use for wide variety of lumbar pathology. So UB is indicated all lumbar disc herniation, which is one of the most common surgery is that what we perform. Let's take a look at some cases. My first case, 49-year-old female, severe left radiating pain for 2 months. Pre-operative MRI showed extruded disc herniation on the left side, L5-S1 level. This video, intraoperative UBE video, you can see that the visualization quite excellent, and we are able to visualize of all surgical anatomy. In this video, the herniated disc compressing left S1 nerve root, and the end of the UBE, we can see discectomy was well done, and S1 root was well decompressed. These are intraoperative images. Left side intraoperative image of the disc herniation pushing up against the nerve root and causing symptoms. Right side postoperative image, nerve root is well decompressed. This is postoperative MRI after UBE surgery. My second case is a 66 years old male presenting severe pain in both legs. Left leg pain was more. Preoperative MRI showed central rupture disc of alpha 5 level. Oh, sorry. Here you can see his intraoperative video. This intraoperative video shows us the rupture disc removed well. You can see all anatomic structures very clearly with UBE. There is no possibility to do mistake, in my opinion. This is intraoperative images. On the left side, spinal cord and root is compressed by the herniated disc. On the right side, you can see that the nerve is nice and decompressed well after the UBE surgery. This is post-operative MRI shows the complete removal of the disc. The third case is 40-year-old male with a severe radicular pain on his left leg for 1 month. You can see on his MRI L3 for extraforaminal disc herniation. Oh, sorry. And this video shows the paraspinal approach for extraforaminal disc herniation. You can see here that the endoscopic view is really quite excellent. You can also see capillary vessels of the nerve roots. And the disc herniation is decompressed. In this photo, in this postoperative MRI and CT, we can see that foraminal disc herniation was removed and the patient's symptom improved after paraspinal UBE. This is last case, 55 years old female, severe leg pain, left leg pain for 3 months. She underwent microscopic discectomy 1 year ago. And this is intraoperative video shows to perform recurrent disc herniation was removed by UBE. This is post-operative MRI. Recurrent disc herniation was removed and root was seen freely. This is clinical study that compare biportal discectomy from microdiscectomy for lumbar disc herniation. Dr. Kim and his colleagues look at 1 year follow-up, and they found that both groups had significant improvement back and leg pain and disability outcome after surgery. And with biportal group, they found that improvements to back pain 1 week after surgery. Significantly better is compared to the microdiscectomy group. There was no complications in the biportal group, with 1 case infection with the microdiscectomy group. Here we can see that the back pain score are significantly higher, but then equalized at the 12 months later, and there is no difference in the score of the leg pain or disability. So to conclude, biportal endoscopy is quite a versatile and powerful technique. It allows us to do surgery which only was able to do with microscopic and tube or even open techniques, and now we are able to do with even smaller incisions to perform the same surgery. We can visualize even better as compared to the microscopic technique, and we can perform a safer surgery. Then we can get a better result. Biportal technique is an advanced endoscopic technique, so that allows us to utilize this technique variety of lumbar conditions and all type of disc herniation. I would like to thank you for kind attention. Also, I would like to special thank to Dr. Professor Hayati, who is my UBE teacher and my leader. Thank you very much, my professor. Thank you.
Very much. May I ask how many lady spine surgeons are in Turkey? You are the only one?
A few, maybe fingers number, yes, few.
And that means professor has to teach more ladies, huh?
Yeah. no, just me.
Actually, there are many neurosurgeons, ladies, but Chile maybe they just one endoscopic surgeon here.
May I call Professor Ati to give his lecture so that we can. You see, you have loaded your this, no?
Thank you, Chairman. Dear colleagues, my second topic is about the cervical UBE. Actually, in some circumstances, we need the anterior and posterior cervical surgery. But in some elderly and comorbidity cases, it's not so easy to make anterior posterior surgery in a same time, same season. So for these cases, we did the combination, surgical combination. We add the posterior endoscopic decompression to anterior decompression. Especially, you know, in the cervical canal stenosis is a common public problem. You know, we can see at least about 5% people but we have some risk factors. Is it possible? Can you change this? Okay, I think okay. Is it possible to make? No, good. Okay, no, okay, now working. Okay. Yes, the multivariate logistic regressive analysis shows us if the disc bulge greater than 2.4 millimeter in angular motion, we can see the dynamic stenosis. It means that if you have anterior stenosis in cervical, when you change the position, when you change the cervical position to extension, you can face with very severe stenosis. It's called as dynamic cord compression. In flexion, if you look at this picture, in flexion, we see just anterior stenosis. In the neutral position, still there is no severe stenosis. Still there is anterior stenosis, but in extension position, you can face with very severe stenosis. You know, anterior surgery doing under the spine position and the cervical spine extended position. And also in anterior after surgery, we can see some complications as named as the anterior cord syndromes or even some reperfusion syndromes. Maybe it's coming from the adding the dynamic cord compression during the surgical intervention, anterior intervention. So like these cases, if the stenosis combined with the posterior dynamic cord compression before anterior surgery, the posterior decompression is make a safe surgery. You see here, we need to extend extension position if we want to do the cervical surgery, especially in the upper levels. Then, when you turn the patient extension position, you can see the dynamic compression. Like these cases, we're adding the unilateral biportal cervical endoscopy. We have actually, again, the two main approaches, like other levels, other regions, paramedian and the paravertebral. And lastly, we developed direct central decompression. I will show you. Yes, surgery started with the triangulation of endoscope and tool, then working space is creating, and we will see the further. Here is our anatomic landmarks. in AP position, we should be same level with the mid portion of the spinous process. In the lateral, maybe the tool and endoscope should be met with the same line with the inferior end plate of the superior vertebra. Okay, let's see the video. Here's the lamina, just here. Seeing the inferior border of lamina, very important. Yes, we doing we using the diamond burr to make thin the lamina before decompression, because we should be aware of that we have no enough space to put the kerosene punch mount enough. If you push it, you can cause the complications. Then we are removing the paper thin lamina gently. After then, you can see the calcified flavum also removing with some part of inferior lamina. Now we gaining more space posteriorly, and also during the anterior surgery, we will be in safe. Now you can see bilateral decompression. Interspinous or central approach. In the interspinous space is the initial target point. Anteportal points are placed on about 0.5 millimeter lateral of the spinous process or ligamentum nuchea. Portals are passing the skin and trapezius aponeurosis by sharp incision, and portal are passing between the splenic capitis and the semisplenius capitis muscle fibrils as bluntly. Then working space are placing between the multifidus muscles on the interlaminar foramen. As you see in this picture, this is the our portal points, and here are our working space. Now, other procedures are same with the other techniques. Now you see here again, this is the superior lamina here. If we do the open surgery and posteriorly, maybe we will have to put the screws and the posterior instrumentations, because we are doing the anterior and posterior surgery for this case. After some laminotomy, here's the midline. Before I'm using the sharp shavers, sharp burrs. After then, changing with the diamond high-speed burr. I want to make a poster, it's not. Actually, I changed this video before. I think I forgot to change with the slide. Okay. This is the case, you see, the preoperative and the postoperative. You see here the 3-level endoscopic decompression and the anterior partial corpectomy and the interbody cage and fusion. This is interesting case. He had the chronic renal failure. Because of this, he was dialysis bounded case. He had very severe cardiac problems. We planned the anterior endoscopy and posterior endoscopic decompression and anterior corpectomy. After surgery, we're still waiting for anterior corpectomy. I know he has a little bit local kyphosis, but the endoscopic decompression works for this case. As a conclusion, dynamic cord compression causes worsening of the cord deterioration during the surgery. Gaining more space for spinal cord can reduce the spinal cord direct manipulation during the anterior decompression. Endoscopic posterior decompression before anterior surgery can prevent of dynamic cord compression due to extension during the surgery. Posterior endoscopic approaches are effective in severe cervical stenosis, even in multi-level. Thank you for your patience.
Thank you very much, Doctor, for incredible. And Dr. Seme, ask one question, please.
Okay. Thank you, Professor Hayati, for this excellent presentation. I have understood from your presentation, and you can correct me. You are depending mainly on dynamic MRI for diagnosis of low pathology.
Yeah, especially in multi-level stenosis. If I planning to anterior surgery, ACDF, for example, but we have more than one level, or we need the corpectomy. It means that I need the longer operation time. So if the case has dynamic the cord compression, after surgery, I will face with some complications.
But in literature so far, there is no solid base that dynamic MRI is the mainstay of diagnosis. You have to add on some other diagnosis to be sure that you are targeting your pathology.
No, you know, the radiology is just a kind of helper. The clinic is important. If your patient has some symptom is worsening during the extension and the compression position, you should be confirmed by dynamic MRI.
So it's like saying shadows are deceptive. Clinical touch is important. Thank you.
Okay.
Now we call upon, we are running 1 hour late. Can I call upon Dr. Paresh De? He will give both his presentations together because he has to catch the flight. Dr. Paresh De will talk on extraforaminal discectomy by Destandu technique. After Paresh De will be having Dr. Arvind Kulkarni. Please open your presentation, and Amit Jala also transition to endoscopy. They have some assignments. They were kind enough to come.
Thanks
Yeah.
for the organization to give this organizers to give me this chance to speak in this August gathering, and also give a chance to operate one surgery what we saw yesterday. That was a discectomy technique, discectomy. I like to thanks the Malcolm and my professor sitting here, my teacher, Dr. Antau. He is my arthroscopy teacher, and all the team of the Malcolm. So this is first talk is the extraforaminal disc herniation by discectomy technique. This is the slide that shows that central disc, paracentral disc, extraforaminal and foraminal disc. Say, as you know, the extraforaminal disc herniation is associated with the compression of the exciting nerve root and all other discs that usually compressing the traversing nerve root. And the exciting nerve root usually the far lateral one, and usually gives the intractable pain, the leg pain. In micro and the tubular surgery, the paraspinal muscles they split, but we usually go for the paraspinal and this subperiosteal dissection of the muscles. And this is a lady, 60 years, occasional back pain with the severe right radiculopathy for 4 months, tingling and numbness up to the lower leg, and the conservative treatment fails. This shows there is a right side L4, L5, right side extraforaminal disc here. So localization and the special localizing device that we saw yesterday, that was a special localizing. We are putting the C-arm in this position, the lateral. No need to take the epi view here. And for the extraforaminal disc, we take not the interlaminar, this is the foraminal, sorry, this is the disc space, and we take about 5 mm cranial for the extraforaminal disc. At the direct posteroforaminal approach, it is the posterolateral approach, and transforaminal approach through the combination is different. It is the direct posterior approach. It is interlaminar, not is the interlaminar. We are docking the instrument little laterally at the isthmus and at the pars. We are approaching from the lateral aspect of the pars. So the docking of the instrument is the same, almost is about 15 mm away from the midline, and it is about 16 to 20 mm long, and also the 5 mm cranial to the disc space. So this is the right side approach, L4, L5. This is the cranial, caudal, midline and lateral. And this is the lateral aspect of the pars. And this is the disc, the white glistening structure. And the nerve root is always cranial to the disc here in the right side. The nerve root is here. So irrigation with the normal saline, and the sometime we are putting the gentamicin. So this is the nerve root. Is well decompressed. It is the disc space. The same patient the next day morning. So what we are putting the disc space, and this is the 5 mm almost cranial. Sometimes it is very easy to see the two level. This is it's called dual approach. Maybe sometime it is necessary. Then this is the interlaminar and this is the extraforaminal. So this is the pars. If you go medial, you will get the interlaminar. Go little lateral and cranial 5 mm, you will get the disc, extraforaminal disc. So this is the traversing nerve root. This is the interlaminar area, and this is the extraforaminal disc or extraforaminal area, and this is the exciting nerve root. So extraforaminal, foraminal, and the axillary. Another patient, 41 years male, is a volleyball player. Came to me with the atrophy of the left thigh muscles due to the extraforaminal disc at L3, L4, and at the same time there is a disc. This is 3 level 3, 4, 4, 5, 5 S1. This is the 3, 4, left side extraforaminal, 4-5 foraminal disc, 4-5 is foraminal. This is extraforaminal left side 3-4, 4-5 is the foraminal, and this is the central disc at L5S1. So what we did, they marked the 3-4, 4-5, 5S1. This is not the disc space, is about 5 millimeter cranial. This is the extraforaminal area for 3-4 level. So this is the left approach, 3-4. So this is the cranial here, because it is a left approach. You will get the nerve root here. And this is the intertransverse ligament that we got now. And this is the disc. So everything is in front of you, as you saw yesterday. It takes very less time. So nerve root is here. If you remove the disc, then you will get the nerve root decompressed completely. So this is the nerve root. Free, mobile, everything. So Dr. Anta told me that this is the, I have to leave for the airport. So I'll go for the next talk. So any question for this extraforaminal disc? Now I'll go for this recurrent disc herniation. Any question, or should I go proceed? Okay. So the endoscopic discectomy, same the distensive technique for the recurrent disc herniation. As you know, the most common complication after the lumbar disc herniation is the reherniation. For the major issue of reherniation is the visualization for the scar. So complication like the 3 to 4 times higher, that is mostly the dural tear and the nerve root injury. The fact that majority surgeon prefers the standard open surgery for the visualization. But for that, you have to sacrifice a bit of bone that may lead to fusion surgery again. So what we have discussed from morning, that is a panoramic view, endoscopic vision, provides clear differentiation and neural structures from the scar tissue, and also adhesive lysis. So upward, downward migrated, lateral disc, and this lateral canal stenosis, L5S1, there is no iliac crest because we are docking the instrument directly. So it's very important for the, we have to avoid the fusion surgery also by this endoscopic technique, by the panoramic vision. And it is a mobile operating tube. You can mobilize in all directions, left, right, medial, cranial, with the help of the left hand with the suction tip, or maybe with the right hand with the operating instrument, or in the coordinated way. We are putting the position in the knee chest position, so the increase the interlaminar space. And then they give the spatial localizing device, few instruments, and this is the interlaminar docking the instrument. As I am putting the patient in the knee chest position for last 15 to 16 years, so I take about 40 seconds to 1 minute, because all of my anesthetist, additional staffs, everybody knows how to do that. The pen is sterile, and then give the mark with the marker pen, with the C-arm in the lateral position. This is the center or midline, and this is the lateral approach. I do this adrenaline with xylocaine, loaded at the spinal laminar junction to reduce the bleeding, drap, and then incision is about 15 to 20 millimeter, 10 millimeter away from the midline. Same for the recurrent disc. And the tissue, we are putting the gauze piece tied with a thread, one cranial, one caudal, and duct the instrument. I use the 3D endospine system that starts from this January 2022. Previously, I was using 2D. So we need that black dark glasses for the 3D. So this is a lady, 62 years, undergone open laminectomy and the nerve decompression, 2 level, 455S1 in 2012. After 2 years, 2014, there was a starts the crippling pain, and there was a recurrence. Then she took the epidural that was subsiding 3 months of pain. Again, there was a severe pain. You can have this wide laminectomy done 455S1, open surgery, and there is a recurrence. The right side, L4, L5. So we approach the facet because there is no lamina. So whatever the remnant you have, maybe facet, maybe isthmus, whatever. So here it was the facet. So tricks is the just approach the facet and then remove little bit of the medial aspect of facet, and nerve retractor pushing the nerve medially with the scar without touching the scar. So to avoid this, touch the scar. If you injure the scar, there may be every chance to injure the dura. And 3 mm disc forceps. So this is the technique. If you have the gutter between the scar tissue and the remnant of the bone, then everything done in front of you. Same technique. So in endospine surgery, the coexistence of the lateral stenosis does not matter because you can remove the bone very easily and very fast. At the same time, bony decompression does not lead to the higher fusion rate also. So another patient, 455S1, disc herniation, almost one level below. It is migrated downward, almost L5S1 up to. And then they operated in 2016 January, and there was recurrence after 6 months. July, he came to me. So again, these are recurrence at the right side, L4, L5, right side, extruded and migrated, recurrence. So same principle. If there is a bone of the facet, we have to trim the facet medial aspect very carefully without touching the scar tissue. Then we make a cleavage, use this nerve retractor, push this scar tissue medially, then go in between the scar tissue and the bone. So this is the disc. A lot of material removed. So this is before surgery situation of the patient, severe pain, and after surgery next day morning, no pain at all. Sorry.
Some problem?
Yes, cut it out. So another patient, this is.
Your screen is not seen.
Kim? Okay. Say 20 years male, 2017 3445 surgery, recurrence in 2020 August. Again the 2-level recurrence 3445. So this is left side. There is a pseudomeningeal seen in the right side, but patient complaint was in the left side. So we approached both the level with the same destined technique. There was a open surgery, now destined to 3445. Another lady, she was about 27 years. That time there was a disc herniation at D12L1 and L3L4 and microsurgery done. Then again 2016, there was a L4, L5 disc herniation, also microsurgery done. So first one is the, this is 2021. That time she became 34 years. First time it was 3-4 and D12L1 in 2014, 2016 4-5, 2021. This is the situation. Patient is having a lot of scoliosis and for last 1 year. After the second surgery, she didn't agree for the surgery. So this is the position. She had the 2 kids. She was the sportswoman, but this was the situation. The recurrence at 3-4. So we plan for the surgery. Recurrent disc. Short video, you can enjoy this one. The same principle, just whatever the bone you have, tackle that bone, sacrifice a bit of bone medial aspect, don't touch the scar, and then you go inside the disc. So this is the position, situation of our for last 1 year. Before surgery. And this is the next day morning, going home. So I'm not going to the detail of the next surgery. So this is the whole set of instrument you can remove. Very short time. We are putting 3-4 subcuticular stitches after irrigation and cleaning. I've operated around say 62 cases this 12 years of the recurrent disc, upon 49 after micro 10 and my cases 3. So to conclude, the endospine system is a safe tool for the recurrent disc. Visualization is the same as micro with the 3D endospine system now, that the depth perception is very nice. Superior in recurrences like the central disc, upward and minor, because it is a mobile operating tube. And not a steep learning curve, because anatomy is the same as micro or open. Thank you.
Thank you, Dr. Day. We are very proud of you. And how different is routine destandu vis-a-vis the far lateral destandu? How in terms of bleeding, in terms of finding the right spot where the disc?
Yeah, bleeding is a little bit more sometimes because of this particular vessels. That if you are having this bipolar, and I am now, you have the on the what is that, RF also, because I am an arthroscopic surgeon, so I have on the table RF also, so no issue. Bleeding is just takes maybe 1 or 2 minutes, and the muscle sometimes come on the mouth, that you have to tackle. That you have tackled by, as I am now having the almost 16 years experience, so that is not hurting much, creating not a problem for me.
And in this 69 cases of recurrence, what was the cause of the
mostly after the open surgery, and maybe after 3 years, 4 years, 7 years. So maybe mostly the degenerative. Only one patient, the second patient, I saw that that was operated in January 2016. After 6 months, he came to me. I removed a lot of disc. Maybe that was a left out disc.
Incomplete disc.
Yeah, maybe incomplete.
Because to find after 10 years, 15 years at the same level, does the disc regenerate?
Degeneration mostly. Regeneration, once degenerated, then the nucleus become weak, and along the pathology develops, and then the osteophytes. All these things counts.
Okay, thank you. We will not hold you much. Have a safe trip back home. Thank you very much for coming.
Thank you,
We
everyone.
really appreciate your
Thank you.
commitment, your skillful surgeries. Thank you very much. I now call upon Dr. Arvind Kulkarni. A lot of people are waiting to see you, Dr. Arvind. He will talk to us on degenerative spondylolisthesis, when to fuse and when to decompress. After this, yeah. Dr. Maris Perez will be the next after Dr. Kulkarni. Please open your presentation and keep ready. Yeah, after Kulkarni is Dr. Jala. Okay, sorry.
I thank dear friends and colleagues. I thank Dr. Nicholas Santa for his kind introduction, and also thank Dr. Prestonji for inviting me. It's an honor. It's like your system is not working and you just want to open the patient and finish off with the discectomy.
No, they have read so many of your articles and books, and they were just wanting to see you in person and hear the presentation. Yeah, you are a VIP spine surgeon. That's why there is a security alert there, no?
So thank you for the patience. So if you want to have a war in the conference, if you want to have a fire in the hall of the conference, the matchstick is degenerative spondylolisthesis. It sets the house on fire, this particular topic, because we have two strong teams, an army which promotes decompression alone, and another big army with its screws, rods, and cages which supports fusion. So this is an ongoing fight, it's basically black and white. The reason being, there are no standard guidelines. There are no rules. So where there's no rules, there's anarchy. So we try to get some sense into this, and we published this article about 2 years back, based on our experience of close to about 12 years. So the issue with management of degenerative spondylolisthesis is, the biggest blunder is that we consider this as a homogeneous entity, which is it is not, by both the polarized groups, that is the degenerative group, the decompression group, as well as the fusion group. They consider this as a homogeneous entity. One considering it to be a totally stable situation, another considering it to be a totally unstable situation. That is the reason. Secondly, these go back to the medieval times when the virtues of minimally invasive spinal decompression were largely unknown. So this is not a homogeneous condition, as things will reveal. This flawed theory of homogeneity of degenerative spondylolisthesis can lead to overgeneralization of a multifaceted pathological entity. It is oversimplifies a complex pathological entity, and in case you're fusing, you're subjecting them to a relatively longer surgical procedure, and added to that are its morbidity and the costs. So this has been reflected again and again in our textbooks and journals. So degenerative spondylolisthesis is not a homogeneous entity. It is a melting point of heterogeneity. We are all mature clinicians. We see in our practice They come with different clinical patterns. They come with different radiological findings, and they have a different morphometry and morphology. So one case of degenerative spondylolisthesis is not similar to another. So when you're comparing outcomes, you're comparing apples and oranges. So we try to bring some sense to it by digging into our previous experience and bring out a formula and use it for our next wing of the study. So this particular study had two components: a retrospective component. This was to conceptualize a scoring system to guide treatment based on a previously operated cases of one-level degenerative listhesis. And this formula we wanted to test on this scoring system. We wanted to test on the prospective cohort. So these cases which were done between 2007 and 2011 were analyzed. So these are all patients with L4, L5 who had undergone surgery for L4, L5 degenerative spondylolisthesis. So we looked at the factors that we considered important in our decision making. So wherever the patient had mechanical back pain, not diffuse back pain, mechanical back pain, so that patient scored 2. When the patient was young, that means the spine is active. That was about our cutoff for 70 years. So the score was 1. High activity individual, based on our assessment of the patient, his basic demands, his lifestyle, etc. Based on this, patient with high activity was scored 1. Then these are all clinical parameters. Then going to radiological factors. So anyone who did not have any movement on flexion extension, 0 angulation, 0 translation, scored 0. While angulation scored 1.5. There's this segmental kyphosis, because kyphosis means an empty disc, and translation scored 1. And we all know that these wet facets, they're a sign of instability. So sorry, this is a orientation of the facet. Coronal facets are protective, and sagittal facets are a clue towards instability. So a patient with a vertical facet scored 1, and with the one with coronal facet scored 0. And facet effusion scored 1, and no facet effusion scored 0 again. A tall disc here, which was we compared with the adjacent disc. So L4-5 was compared with the L3-4 disc. A tall disc has a tendency to degenerate and slip with time. So it is like an inflated balloon. As it degenerates, it slips forwards. So a short disc is relatively a stable condition, which got 0 marks. So the higher the scores, more towards instability. Again, the morphometry of that particular segment. So in this case, on the left side, you would do a central laminectomy, wherein you sacrifice the interspinous, supraspinous ligament. So this probably moves more towards an unstable situation compared to the image on the right, where we have coronal facets, a burnt out facet joint. This is not going to budge. So we put all these things together, and one was the clinical parameter, second was the radiological parameter, third was the anatomical parameter, that is a technical parameter. So this was applied to all our patients. These were the things we were assessing when we were deciding decompression or fusion, and this was this particular score was then prospectively applied to the next bunch of patients, and we did again assessment of their ODI, VAS, back and leg pain. So in the retrospective study, we found that out of 131 patients, in 41 patients, almost 1/3 of patients, we could just get away with decompression alone. And they had similar outcomes in terms of their ODIs, VAS for back and leg pain. And the magic score was 6. And this group of patients who had undergone decompression alone scored less than 6, and those who had undergone fusion had scored more than 6. So that was our benchmark. And this, when we applied to the next set of patients strictly, so we found that 1/4 of the patients that we operate in the next few years, we could just do a decompression alone. So out of which about 4 of them failed. They developed instability, back pain, etc. So because of which they underwent fusion. But almost 1/4 of the patients were saved from fusion. For example, this particular patient, she is a elderly lady, 70 plus she has a very low impact, low intensity lifestyle. She doesn't have any back pain. She has just radicular pain on one side. You see, if you go by the scores, she just scores 1, she has just some degree of translation. So the score of 1 wouldn't justify, a fusion procedure in such a lady. So she has Decompression, which hardly moves in flexion, extension, and neutral. You can see it here. And you can see the coronally aligned facets that she has. It's a burnt out facet joint on both sides. So we have technically we have described it in many of the platforms. This is the well-known procedure of ipsilateral contralateral decompression done for stenosis. It is a stabilize. It has an impact on maintaining the stability of the back. So you can see this. This is a pre-op image. The canal is widened, all done through this tube. And you can see the pre-op axial images, the lateral recesses, which are very tight, are free now. You can see here. So just a small incision of about 1.5 centimeters. So this is all that this lady needed. So why fuse her? So this gentleman who's carrying the legacy of the queen, he was fingering. So this is a case of degenerative listhesis. You think he is fingering. It's a case of degenerative listhesis based just on one particular X-ray. So the minute you see it, you shouldn't think of screws, rods, cages, etc. You should holistically see the patient, in all angles. You do flexion extension X-rays, you do the patient's MRI. You see here that there's hardly any movement in flexion extension. The disc is not tall as compared to the other discs. And you can see it's like a fortress, the facet joints. This is the superior facet of L5 is not going to budge, allow this L4 inferior facet to, budge anteriorly. So when you see he's asking for a threesome, he's not fingering somebody. So the entire decision and entire understanding changes after you see all the images and the patient. On the other hand, this is a patient who has florid instability. Back pain, young, significant movement in flexion extension, vertical facets, severe effusion in the facet. So this is straightforward case for a fusion. So it works both ways, this particular scoring system. So, we shouldn't criticize our past surgeons because they did not have the facility of MRI. Things were done based on myelogram, X-rays, etc. So everyone and anyone who had stenotic complaints, whether with or without listhesis, underwent this Christmas tree decompression, where the roots were shown till they were miles away from the dural sac. So this basically resulted in a situation where the patient did not get up from his bed the very next day. So landing in severe back pain, leg pain, neurological deficits, etc., which in turn made Herkovitz a hero because he is the one who actually suggested fusion for degenerative listhesis. And many surgeons followed this hero, and the flag of fusion was flying high. And what made it boom further is this pedicle screw market, which boomed at the same time. So everyone with degenerative listhesis was fused. So earlier all were decompressed, then all were fused. But this understanding is very poor. So fusion for all patients is not the right way to go, as I showed you. It's a relatively longer operation. It's more morbid. It's not free of complication. The basic reason being it is not a homogeneous entity because many factors, as you see, influence our decision making. So the current thinking should be to customize treatment for each individual patient. So even in this hall, 40% of us may be having a slip of more than 3 millimeter, which is asymptomatic. Again, we are all experienced surgeons. We know that grade 1, degenerative listhesis, unlike lytic listhesis, doesn't progress beyond grade 1. Majority of the times, even after you decompress, it restabilizes. And radiological progression does not correlate with clinical progression. We see it all the while in our clinics. And 85% of these patients with degenerative listhesis don't even enter your clinic. Again, we forget that, with time, the disc, which takes 80% of the load, the anterior column becomes hard, becomes calcified, becomes tough, and it itself is a big stabilizer. So this we had shown in this paper where, patients with a hard disc with stenotic complaints, you can just go do away with lateral recess decompression. And then there is tons of literature now, which has answers to, questions like what is the incidence of progression after doing a decompression? Just 2.6%. What is the possibility of having a second surgery because of instability following a first surgery? Just less than 1%. So there's tons load of encouraging data from the minimal access side. Again, you can't compare the cost of a decompression versus a fusion in terms of everything: number of OT hours, implants, analgesia, etc. So there's another paper which we had published long back. This was our experience based on patients with synovial cysts, facet cysts. Again, the standard teaching is to fuse all of them. We fused just 3 out of 33 patients who came with synovial cysts, and out of these 30, 8 of them had degenerative spondylolisthesis, and they were just decompressed, and they then went home successfully. So this is the scoring system which is published. So this particular scoring system is holistic in nature. It takes into consideration clinical parameters, patient's demands, dynamic radiographs, MRI findings, the technical possibility of performing just a decompression alone, etc. So this is a paper which is just still not published in the Spine Journal. This is the title is Current Treatment and Decision-Making Factors Leading to Fusion versus Decompression for One-Level Degenerative Spondylolisthesis. This is a hot topic. This is a survey of results of members of Lumbar Spine Research Society and SMIS. And our paper has been widely discussed in this particular paper, because ours is one of the very few papers which strongly, with the strong title of Fusion versus Decompression, which questions, which give some direction to decision making in degenerative spondylolisthesis. Again, there are limitations. It's a single surgeon, single center study. It's not a randomized control study. Again, minimally invasive decompression, especially for stenosis of this kind, is technically demanding. Not everyone may be trained in doing so. So hence technical expertise is paramount, especially in severe stenosis. So the current literature fails to systematically subclassify patients with degenerative spondylolisthesis. It is a heterogeneous condition requiring surgical intervention tailored to each patient. So unlike fusion, decompression also has a central place in the management of degenerative spondylolisthesis. The degenerative spondylolisthesis scoring system, which you saw, is a reliable tool in planning treatment in such conditions. Thank you.
Thank you, Dr. Kulkarni, for such a scholarly presentation, which we are looking forward to, and the classification, which is on for all the world discussion to come for the final, what would say, the rules or scoring system, right? Yeah. Any questions? Your lecture is so self-explanatory.
So first, when the patient comes, he comes with a standing X-ray only. There's no lying down X-ray. So that gives some clue of instability. So then we do a flexion extension X-ray. So from that is the baseline from which you do flexion extension X-ray in standing position.
Because in a 3-tier city, I mean, it's sometimes difficult to get a standing flexion extension X-rays. So do you follow anything else, sittings?
As a rule, I always ask my patients, even if they come initially, whether it was done lying down or standing.
Thank you.
It's very important to get standing X-rays.
Now, most people do standing, right?
So, Shesha, there's a comment for that. If you can't get a flexion X-ray in standing, you can get a lateral knee chest position X-ray. It works almost the same.
We do get a flexion extension X-ray sometimes if it's not possible. But it is supine.
On the other hand, if you don't have flexion extension X-rays, you can do a standing X-ray and compare that with the MRI image. MRI is done lying down, so that is an extension. So even if that shows some degree of movement, so here it is not just flexion extension X-rays. Even if you have a MRI image wherein the T1 image shows hypointensity in the disc. So that means it's a vacuum sign. So that also adds to the point by 1.5. It's just not. It's basically dynamic instability that you're looking at.
Okay. Sorry, we have to cut short the discussion because of they are waiting for their flights. They should not be delayed. Dr. Jala, Dr. Kulkarni is always available. Besides his scholarly studies, he's also talented in music and art. Amit Jala will talk about transition to endoscopy. Is it worth it? Next is Marisa. Please open your presentation.
Yeah, again, thank you, Dr. Pestanji, for inviting me to this meeting. I've learned a lot in this meeting and a lot of advantage to me for this topic that I'm going to talk on, transition to the endoscopy. As everyone knows that I am more of a tubular retractor person, which I did for last 20 years. And now whether I should transit to the endoscopy or not. So that is one of the thought that is always going on in my mind. So I try to have this thing. So what I've been doing is tubular system, it's a versatile system and you can do any type of the disc prolapse. That's what now the endoscopy persons are also telling, that you can do any type of disc prolapse with the help of the endoscopy, which was not the case before 20 years when we started this procedure. And it was all the tubular system which was taking over the endoscopic persons, because you required a specific things for endoscopy which was not available at that time. So this is how we started. And even this severe canal stenosis at that time, we were able to do it, as was shown, with a very good decompression on bilateral with a uniportal approach. That what now we are doing by the endoscopy. So this is what the stage where I started before 20 years. And even if it was a missed TLIF at 1 level, 2 level, it was very easy procedure for us to do. So if you see my journey in MIS, so we started in 2002 with MED and endoscope. So that's how we started. And we started with the discectomy and over the top at that point of time. In 2007, we started with MIS TLIF, when even the routine, we were putting the routine screws, these systems were not available. So we're just putting directly the owl and then putting the screws without the K wires. So that is how we started in 2007. In 2008, we shifted from endoscope because endoscope was not available from the tube that was taken by the Medtronic, which was initially marketing it. So they took it out. So we transited to tubes with a microscope in 2007, with an added advantage that you can use the whole area of the tube. And then in 2012, I transited from that for an anterior ones for doing a DLIF. And if you see in 2016, I started doing OLIFs and endoscopy, both the things. So you can see there are a lot of transitions in our whole journey of our spines as a spine surgeon as a whole. And every transition has, you have to have a change. And that change is very, very important, because change begins at the end of your comfort zone. So if you are comfortable with one particular procedure, so I was comfortable for 20 years with tubular system with excellent results. I don't know whether I should transit from that good result to an endoscopy, because the transitions come from change and with its own set of complications during the learning curve. So that's very, very important. So there are issues of transitions to the endoscopy. You have to come out of your comfort zone. That's the first thing, that you are very much comfortable. And as Ajay talked in the morning, that you always try to compare that the same thing I would have done with my particular system. I would have completed in that much time. I would have got the same or better results. So that is a comfort zone. You have to come out of that comfort zone. It's time consuming. In the morning, I was just talking. We took UBE about 4 to 5 hours. And then there is a mind which goes on that I could have completed that in 1.5 to 2 hours, the whole procedure. So you have to invest in time. Though it is a time consuming, initially when you are starting with any newer procedure, it's going to be time consuming. When I started the tube endoscopy, it took me around 3.5 to 4 hours for one disc, which I could have finished in 20-30 minutes and in an open procedure at that time. So you have to invest in time. That's very, very important. It's a high cost procedure. Everyone is talking about the cost, but I know that when I started with all these things, the tube was very costly. Then the technology advanced and these costs do come down. So even the endoscopic cost is going to come down. So that's not a major issue. So it's a very steep learning curve. Yes, compared to others, it has a steep learning curve. So you have to invest in time. There is a fiddle factor and frustration sometime that it's a simple thing. I'm not able to reach there, right? Today morning, we had that for one little fragment that was not coming out, right? So that's a frustration, but that's not, you have to overcome that hurdles. So there are apprehensions of inadequate procedure, apprehensions of increased complications, and apprehensions about the outcome of the procedure. And then why to start all over again? There are rigid ideas which develop after so many years of your spine practice. Okay, so these are the issues why we should transit or not. And you have to again develop all the skill sets that you have handled. You have to handle again the handling of the scope and all that. So these are the factors. So I'm just giving you 2 cases. This is during my transition phase. And then this is case 1. It was a disc prolapse. And you can see that this doesn't move. No. Yeah. So these are the videos. But you can see that I was just doing the endoscopy for this thing, and I reached at the axilla, and then I had to extend this because I had reached the axilla, so I need to free the root, so I had to extend it upwards, the incision, and I was not able to retract this much. Okay, this is the root, and I was not able to retract the root. So then when I tried to do with the punch, and you can see that I got a cut of the root and I got an injury to the root. Of course, it was only the perineal part. It was not the whole root. So I could, and this is, you can see that there was a tear, and still with the help of the tear, I was able to do the whole procedure. But you can see that there was a tear there. You can see that roots coming out of these things, and there was a tear. So the thing is that you always have that why we should have this stress in the mind. Okay, so and that was a root injury. And then coming to the next case, so that was another disc which was I was doing, and this patient had, so this patient again got again a similar case, but then this patient again I was not able to retract. Again, I was not able to retract, and actually I was again in the axilla, and you can see that there was an axilla. So again I had to extend it. So once I started to extend it above, and I just caught at that level the dura, and you can see that you will be able to see that there was an injury to the dura. So these are all the procedures which you should not be blind. You have to have that handling experience. And that's where I caught. And you can see that there are a lot of, this were the rootlets which just came out. So they were the rootlets which came out of this. Okay. So then I had to convert because I never wanted. So I converted into the tube and completed my whole procedure. But you can see that the whole tear and the dual tear was there. So this is what it was. So the question here is there a need to change? We have got two complications. You are comfortable with all the other procedure, whether there is a need to change. So what does the literature say? I just went to the literature, and literature does not give you the correct answer, except that the endoscopic, this was projected again by Ajay in the morning, that the publications have increased for the endoscopy. That means the interest, global interest in the endoscopy has increased a lot. And there are a lot of publications which are coming. But if you just go to the literature, discectomy, you will have, there were several RCTs which compare, there is no difference between any of the procedures, whether you do a fenestration, whether you do a discectomy by a tube, or whether you do it by an endoscopy. So the primary thing is that the literature is not going to give you the correct answer. That's what I feel, because everything is going to be the same. If you see the lumbar canal stenosis, the same reports. You have so many RCTs which you can get it, and you have the same reports that all the outcomes are same. Comparative analysis, you can see that all groups had a similar clinical results, even with the stenosis. Lumbar fusions, currently tubular MI still gives the best results, but endoscopic procedures, though perform with the improved results, newer instrumentations and the developments and adoption of the technique have improved these things. So these things are not going to give you what the correct answer, even the literature, because you are not with the current trends which are happening. So what is the global trend as on today? It's significantly growing towards the endoscopy. The surgeon and the patient's demands both are increasing. If you see, there are a lot of meetings which are going, and there are a lot of delegates who are much more interested in endoscopy now rather than any other thing. So there is a global trend towards the endoscopy. The Asian surgeons are more tilted towards endoscopy, and compared to the US surgeons, we don't want to discuss why it is there, but there are so many reasons for that. And 70% of the Asian surgeons perform spine endoscopy compared to 55% of non-Asian, because the whole Asian group is much towards the endoscopy. The majority of the innovations in endoscopy also come from Asia. So what are the future projections? Though it's very obvious that it is least invasive, there is no need to prove. When I started doing tubular retractor, everyone was telling why I should shift from an open to a tube. It was obvious. There is no need to prove that the muscle damage was less. So now there is no need to prove that from tubular retractor to an endoscopy, the muscle damage is much more less. So there is no need to prove. It's an obvious less invasive, less tissue damage, less postoperative pain, and early discharge. So, but all the procedures will stay. That does not mean that endoscopy is there. You have to leave the other procedures. All the procedures will stay in the armamentarium. There are a lot of procedural solutions which will be available for adoption, training, instrumentation for various indications, which are limited today for endoscopy. But in next few years, I am definitely feel that it's going to come. And the healthcare cost, the patients of MIS, they will be discharged next day, or maybe in the evening also. It can become a daycare procedure. So therefore, it's very, very important that the healthcare cost will also come down. That's very important for the patient and the surgeon both. So worth to invest in time and training. I definitely feel that endoscopy is worth to invest in time. Thank you very much.
Dr. Jala, for such a intensive philosophical and for the words of wisdom. Any questions?
Thank you for your nice lecture. I just would like to ask you about the patient satisfaction. In all of your journey in this spine surgeries, starting from the microscopic and endoscopic, what is the best result of patient satisfaction after surgeries?
So everywhere I have a talk. You see, definitely there is no doubt about it. Since 2016, whenever I've started, that's the only comparison that I make. Whether I publish or not, that's a different thing. But every time I see the patient, whether I've done by a tube or whether I've done by an endoscope, the endoscopic patients will have less immediate post-operative pain. So the patients are much better, they work much faster, and they don't complain of post-operative pain that much compared to the tubular retractor system, because tubular retractor definitely is more invasive compared to this thing. That's what my observation is.
Thank you.
Thank you, Dr. Jala. Have a safe trip.
I have,
And thank you.
one comment, please. If we are digging in literature, we will find no superiority for endoscopy on other minimally invasive interventions. But I believe it is unfair comparison, because if we look at the numbers of publications about microscopic intervention, we will find a huge number comparing it to endoscopy. It is not encouraging that you have to be an endoscopic surgeon, but you have to read numbers well.
Yeah,
Thank
definitely.
you.
Yeah.
Numbers don't tell lies. That's the thing. Okay. Can I call Dr. Marisa to give a presentation on endoscopic anatomy of the lumbar epidural space? Dr. Maris comes all the way from Argentina to tell us what we don't see deep inside.
I will give you a break from surgery. I will talk about the anatomy.
You want some help?
Sale distinto acá que ahí.
Okay.
That's okay. Thank you again, Dr. Hassan, Dr. Petonchi. This our University of Buenos Aires, our neuroendoscopy center. I will talk about the endoscopy anatomy of the epidural space. The epiduroscopy is a minimally invasive technique. It allows for direct endoscopic imaging of the epidural anatomy. An advanced understanding of the anatomy is basic for successful clinical outcomes. The history in Argentina. In 1999, I wrote the sinovertebral endoscopic nerve anatomy implications in low back pain. In 1999, anatomical basis for the endoscopic evaluation of the epidural space, and 2000, lumbar epiduroscopy applications in anesthesia and and pain medicine. In 2001, the paper is endoscopic anatomy of the lumbar epidural space. In this image, in the white picture, I describe the ligaments anteriori as posteriori. In the other picture, with R, the root, with B, the veins, y the S, the dural sac. The conclusions in 2001, direct visualization of the pedicles and exit of the nerve roots used in treatment of fibrosis, tumor, abscesses, or other causes of radicular pain, and to assist transpedicular fixation in the future. The epidural space is an area surrounding the dura mater and the dural cuff, and nerve roots extend from the foramen magnum of the skull to the sacral hiatus in combination with the sacrococcygeal ligament. In this picture, see two anterior and posterior epidural space in white, and in green, retrodural space of Focada. The epidural space anterior is the posterior longitudinal ligament, the vertebral bodies, and the intervertebral disc laterally by the intervertebral foramen and the pedicles of the vertebral arches. And posterior, the vertebral arches and the ligament of flavum. The dural sac ends at the level of ACE2. The only tissue caudal to it is epidural fatty tissue with the filum terminale. The sacrococcygeal membrane forms the caudal boundary of the sacral epidural space. The endoscopic anatomy of the epidural space formed by tissue, blood vessels, nerves, and dura mater. The tissue composition, the epidural tissue comprises loose areolar connective tissue, fatty tissue, and ventral or dorsal septa. In the video, see the fatty tissue, the areolar tissue. In this video, the same fatty tissue in yellow, the nerve root, the areolar tissue, and the connective tissue. The fatty tissue acts as a lubricant for the movement of the nerve root in the spinal canal. This is a nerve root, in yellow the fatty tissue, and superior the connective tissue. The blood vessel, it contains arteries and veins supplying the spinal column, in especially epidural venous plexus anteriori, so-called Batson plexus. The arteries branch off from the segmental arteries. In this video, the small arteries surround the nerve root and the tissue, fatty tissue. The blood vessels in this video and the laser work. This is a fatty tissue and connective. And the nerves. All nerves supplying the epidural space branch from the sinovertebral nerves or nerve Luchka. In this cadaveric dissection, this sinovertebral nerve are C, the ramos communicans or rami communicanti, and L4, PE is the pedicle, P inferior the same, and ID interdiscal space. This is nerves in picture, and in the video, the nerves and the dural sacs. This is axilla. In this video, the nerve root and the laser coagulate, and the laser work in the fatty tissue. Finally, the root is free. This is a transsacral approach. In this video, this is L5 S1 nerve root. This is fatty tissue. This is ramis communicanti. And exiting from foramen. Again, L5 S1. This is a foramen and fatty tissue. And dura mater, in this video, the blood vessel, the dura mater pulsing. In conclusion, a profound knowledge of anatomy is mandatory for successful endoscopic procedures of the spine. Thank you again. Thank you for the invitation.
Thank you for your wonderful presentation. Actually, it's very important to know the epidural anatomy. I wonder just, you know, there are many the epidural ligaments, dorsal, ventral, and posterolateral ligaments. Is that important for the endoscopic surgery? It means that they have the potential to make dural tear during the surgery.
Yes. My partner traduce for me. No, sí. Nosotros describimos los ligamentos en material cadavérico en el año 1999, todavía no estaban descritos, que se corresponden con los ligamentos meningovertebrales anteriores, laterales y posteriores.
She wants to say that the first cadaveric anatomic paper that we described in 1999, we especially described those septa that were not described before in endoscopy, at least in Argentina. And we described it especially for what had to do with infiltration of the space, because it was one cause of failure of blocks. They didn't know why blocks would fail, and one reason was this septa that couldn't allow medication to flow freely. We don't have. Somebody asked me yesterday, we had many dural tears with the epiduroscopy, and I have to say that maybe there are inadvertent fistula, but we never had a patient with a clinical fistula or with symptoms of fistula.
Thank you.
Gracias, doctor. Can I call Dr. Hyun-Min from South Korea to talk on current status of biportal endoscopy spine surgery?
Thank you, brother. Thank you for coming. Thank you again, Dr. Malcolm. Thank you for inviting me. It's late, but I was really excited. So my topic is history and the current status of bipolar endoscopic spine surgery. Why endoscopic spine surgery? If you ask me, it's I think most minimally invasive spine surgery and less post-operative pain and faster recovery and less damage for multifidus muscle. So 1998, I visited Dr. Anthony Young in Arizona, and I learned from the Biportal endoscopic surgery by PLD. But now in America, American doctors no need for endoscopic spine surgery because steep learning curve and more time, less money, and non-coverage of policies in the USA. So industry, not economical. So I don't know. I don't understand. I don't care. So there American doctors think like this. But so I tried PLD many times. Frankly speaking, as for me, it's not easy for me. I failed many times, and I cannot get enough decompression. I can see the pathological lesion, but I cannot reach that part. That's the problem. So I dropped. So at that time, I have to try to find out other procedure. So I find out bipolar endoscopic spine surgery. This is actually, I think, endoscopic assisted spine surgery. This surgery is based on the open surgery. So first, we have to know the basic anatomy and the basic open surgery completely. And so not so steep learning curve compared to Biportal endoscopic surgery, but still have a learning curve here. One best important advantage is, I think, you can get a best surgical view because of endoscopic view is 20 times, but microscopic view, if you use microscopy 20 times, we cannot see, we cannot control. Only we can see microscope magnification is 4 or 5 magnification. Also, we can use ordinary spine instrument set. You can use longer, and you can use classic open surgery spine instrument we can use. There is no limitation. And one more important thing is same as open surgery. So biportal, as you see, knee arthroscope and shoulder arthroscope. Somebody asked me, very expensive, but if it is expensive, how can we do shoulder and knee arthroscope? Same, nearly the same. And more importantly, frankly speaking, it's not official. We can use a radio frequency device forever, 20 times or 30 times. So the principle is the same as in the spine surgery, but the difference is in the arthroscopic surgery, shoulder and the knee arthroscopic surgery, already there is a space. But in the spine, bipolar endoscopic surgery, we have to make a space. That's the difference. So two holes and triangular approach. Yeah, UV is actually, if you look at the Parvis-Cambin's textbook, Parvis-Cambin first describe unilateral bipolar endoscopy. You can find it in the internet. Parvis-Cambin, at that time, he first mentioned the unilateral biportal endoscopy. But 1996, DLD Anthony from Argentina doctor, right, Argentina, published this article in 1998. And this is original article, 1996. At that time, they did the lateral decompression position. Yeah, this guy is Indian guy. Now he's living in Bahrain. I met him 1 year before, and I met him 2001 February. Fortunately, I lucky to chance to meet Dr. Abdul and AAOS and 2001 February in Chicago. So the first time biportal surgery was lateral decompression position. So that in this position we have a problem. We cannot control the epidural breathing well. So that's the reason they are doing lateral position. And also we cannot retract the root well. So that's we have to lateral position. So Korea, I and Choi at that time we run this technique. And notice we change it from position, and we use vigorous radioprecast device, and we made some instrument. So we changed it, developed established since 2001. So there is development. You can see that there is important for the KG insertion instruments. I call it guide and many other instruments. So 2003, I did unilateral biportal discectomy, and there is also learning why I call it press like this. Level one, lumbar and decompression and revision surgery. Level three, endoscopic dural repair, foraminal decompression, cervical discectomy, and thoracic decompression, control lateral approach, and endoscopic fusion surgery. Level four, extreme surgery, and cervical lateral fixation, and maybe future will become. Sorry. Yeah, level one. As you know, herniated disc L4-5 side, downward herniation. Procedure is the same as open surgery or micro surgery, and laminotomy and parametry. So there is three I always tell the students. There is one SAP, spinal lamina junction. Just number one, not. And number two is upper lamina over vertebra. And number three is passage joint area. I call it there are three. Then you have to find the first. So you can see the axillary area. There is a rupture disc. So surgical view is very clear, and you can use all kind of ordinary spine instrument. And with PTH forceps, and we can remove rupture disc without the damage. And also in that we CSF normal cell pressure should be right. So after discectomy, we can do annuloplasty and nucleoplasty with radioprecast device. So just for prevention, and we can reduce the post-operative pain. Always after removal discectomy, I do this job. So level 2, L4-5 stenosis, unilateral laminotomy, and bilateral decompression. Very simple procedure. Also, this is spinal lamina junction and facet area, and this is upper lamina over vertebra. We can decompress unilateral laminotomy, bilateral decompression easily with the biportal endoscopic surgery. So we published the article. I and Dr. Ho and Dr. Sons. This article was published. I'm not good eyes. So level 3, HCD 67, right? So, okay. 16 right side, laminotomy. And foraminotomy. It's the same as open procedure, posterior cervical laminotomy and foraminotomy and discectomy. So, but we can see the anatomy clearly compared to microscopic surgery, especially in the we are doing foraminotomy. Usually we have breathing. Okay, we cannot control the breathing well, but in the endoscopic surgery, because of normal saline pressure, we can see the anatomy very well. And the discectomy. And one more important thing is we can exploration around the nerve root freely with nerve hook, all kind of normal spine instrument we can use. There is no limitation. There is what we can see the remnant disc exploration around the nerve. Okay. So there, especially cervical disc, there are some remnant disc that remains. So you use the nerve hook. So we always, I have to see, make sure there is no remnant disc. And level 3, I think a biportal endoscopic lip surgery, already you know. I'll skip. Okay. Yeah, endothelip, pre-operative, post-operative. Recently, I use titanium cage, and cage position. I want to try to put anterior and transverse line. Same. The post-operative wound is very small, but wound is not important thing. So we published the data. Dr. Ho, Dr. Son Sang-gyu, and I published this article. And level 4, EXLIP. I presented you about this topic before. So the same paramedian approach. And this is transforaminal approach. And post-operative X-ray. So high BMI patient, especially we have good advantage. We can put an only cage L5S1. So this video you saw. So we published articles 2021 and 2022. And this is actually cervical lateral mass screw fixation, C45. Only I tried 2 times, not easy technique. It takes a long time, but I can do it, we can do it, okay? So lateral mass screw fixation, cervical lateral screw fixation is not difficult one. If you know the anatomy. Also, I decompress the posterior part already completely. And then, because this patient have some kyphotic change and the cervical myelopathy symptom, so I decompress posterior decompression completely, and I have to fix the posterior lateral mass screw fixation. Okay, comparison. I think this is only my experience, my personal opinion. PLD is surgical view is fair, but UB excellent, but microsurgery is good. But fusion surgery, PLD, some excellent, talented surgeon can do it, but it's not easy, very difficult. And KG line, anterior and transverse is very difficult. And UB, I feel comfortable because I'm a UB surgeon. But microsurgery, good, also possible. Operation time for decompression, PLD. Sometimes it's very short. Sometimes we cannot decompress well. Very incomplete decompression. But UB surgery, I think is moderate. Okay, microsurgery is normal. And learning curve, I think 10 is more severe. PLD is 8 to 9, but it's different. UB is 6 to 7. Microsurgery 3 to 5. Also, reproducibility is PLD, I think is very low. I think it's for me. UB is moderate to high. Microsurgery also high. Okay. 2022, we visited LA, UCLA, and February 5th, we had the endoscopic spine symposium, cadaver dissection workshop. And now, many American spine surgeons are interested in endoscopic surgery now. So we published this textbook. Yeah. So conclusion, biportal endoscopic spine surgery would be promising MISS. Thank you very much for your attention. No questions, right?
I think our next speaker is Dr. Seok Bong Jung, please. And Dr. Neeraj Jain after that. Dr. Seok Bong Jung, please. After Dr. Neeraj Jain's small talk, we are going to have our young spine endoscopic surgeons strictly adhering to time. They're being given 6 minutes each to give their free papers for presentation. And we have an expert committee sitting here who will be evaluating you. And we have a first prize of 25,000 rupees. So I hope the best man wins.
Okay, thank you, Malcolm, Dr. Malcolm. My third talk is biportal endoscopic foraminal discectomy and decompression in lumbar spine. Biportal endoscopic surgery range of application is thoracic, lumbar, and decompression surgery and discectomy, also revision, and in-the-body diffusion, and the cervical decompression and foraminotomy discectomy. As I said morning, intradural extramedullary tumor. Next. Let me start by looking at 5 different endoscopic biportal surgery. This patient is about migration L45. Right. Watch the video. You can watch the video. Is probe with probing remove the large fragment disc. I have short and middle and long probe. So migrated disc, I always use the long probe, and the complete. We can have complete discectomy. Foraminal disc herniation is slip of right foraminal disc. Let me watch the video. It takes 30, average operation time is 30 minutes. You can see the extending node, dissect the annulus, remove the disc material. We can have a sufficient decompression. Lumbar decompression and stenosis, average operation time is 38 minutes. Left one is severe grade 3 central stenosis. Middle one is sufficient decompression state. Watch the video. Proximal ipsilateral decompression and the ligament problem removal. We turn the right source is up 108 degree. You can see the opposite side is contralateral. You can remove the sufficient decompression. Cervical porotomy discectomy is takes 40 minutes. Remove the ligament flavum, and you can see the axilla portion. Cut the annulus, remove the cervical disc material. Lumbar interval diffusion is 1 hour 20 to 30 minutes. Watch the video. Medial facetectomy and remove the bone fragment. Preparation of discal spaces and insert the cage. Okay. Transforaminal approach with the biportal technique. Two skin incision is different from interlaminar approach. Distal portal is a viewing portal, and the viewing make incision at above 1 centimeter lateral to the tip of the transverse process. Working portal is make to the proximal at interval of 3 centimeter. Right one is drawing with the slanted angle. This picture is above incision is interlaminar approach. Lower incision is transforaminal approach. Of course, solid scope is so convenient and easier to do a biportal endoscopic surgery with the primary approach. Standard interlaminar approach, right region, left hand working, left region in the right hand working, but primary approach, right region, right hand working, left region, the left hand working is so easy. Right picture, photo is real compared to interlaminar approach. This video is actual surgical. You can see the right source move, turn, and right opposite side. Foraminal discectomy and decompression by interlaminar approach. You can see the by interlaminar approach, we can remove the foraminal discectomy. L45 right one. You can see the foraminal herniation. We can remove the by interlaminar approach. Watch the video. This one is foraminal disc by interlaminar approach. You can remove the big fragment of disc material. Sometimes we downward pituitary use. We can use downward pituitary. This is a post-operative MRI by interlaminar approach. we can remove the foraminal disc. Right one is partially laminectomy. You can see on the X-ray. This drawing is by intraoperative approach. You can remove the foraminal disc. Next one is you can remove the foraminal disc. Right one is post-operative photo. Another one, cut the annulus and do probing and foraminal fusion. Remove the disc, and we can use downward pituitary. Okay, downward pituitary is insert the disc space. Right, lower one is post-operative MRI. Okay, next one is foraminal discectomy as decompression by transforaminal approach. 54-year-old female patient. This MRI show migration of the disc to the proximal side in the L25 foramen, as highlighted by an arrow. You can see the isolated and migrated disc in foramen. Watch the video. Transforaminal approach is this margin is SAP. With astrocare with soft tissue cauterization, and move to the proximal portion in the foramen L23. You can remove the fragmented disc in L23 foramen, proximal foramen. Okay, right one is you can remove the completely remove the completely disc material. Axial view, you can see the have a good sufficient decompression. L3 for foraminal disc. Another case is foraminal annulus. We find the annulus in the cut the annulus and remove the disc in the foraminal approach. Picture below is post-operative MRI. L5S1, you can see the transforaminal approach. At the slanted angle, we made at the slanted angle. So next one, you can see the video. L5S1, you can see the radicular artery. This is left one is ALA. Superior is SAP base. Cut the annulus and remove the disc on L5S1 with the transforaminal approach. Okay, another case, L5S1, foraminal disc herniation case. ALA and the base of SAP, we remove the partially remove the bone partially and remove the disc. This case is if you remove the too much bone from SAP during foraminal decompression and discectomy, this in the CT scan, you can see the sinking down and causes the instability and cause restenosis. So this patient needed to have interbody fusion surgery. Thank you. Practice makes and perfect. Thank you. Thank you very much.
Dr. Neeraj Jain from Delhi, a master spine interventional pain interventional specialist, one of the best persons I know in the procedures of kyphoplasty and many other spine procedures. And he's going to be giving us the last concluding talk of the day, following which we have the free paper presentations.
Thank you, sir, Dr. Malcolm, Professor Malcolm, and the team of the World Congress for inviting me for this special talk to share my innovations, some improvisation in the kyphoplasty, vertebroplasty. It's so pleasing to see so many people around this time of the day. And after talking so much about this, now let's talk about the body and vertebral body. So this is improvisation, and what all we're doing is something new. I think probably it's a thought-provoking also for many. And let's go further on this. This is what is vertebroplasty is all about. I keep teaching on cadaver sections, and we don't have to breach medial border pedicle and don't have to go posterior in the canal and put a drop of cement there. That's what all is vertebroplasty is all about. Yes, I do say that we more slanting I go, better it is. And I started doing with single needle technique lately instead of two needle technique, which used to do earlier. So I'm much happy if I use a single needle. There's a reason for that, because I think second needle is obsolete sometime because your first needle is done a good job. And people have started doing transcambin now. Cambin is being used for so many things. And this is what it is all about. You can put needles, like you're doing so much of endoscopic work today and nursing end plates. You can go through the end plate and do the vertebroplasty there in some patients, or going through one of the body, in the pedicle way. And especially with the angled approaches, one can really do the good cement fill. And with latest with the hook and all, everything, you can do end plate elevation also. If you don't want to do kyphon work, kyphoplasty, these elevations are possible through all this thing. And people have started doing a endoscopic work in the vertebroplasty as well. These are some latest papers I'm just sharing. Now I'm sharing my own work there. Now this is a patient who has been done surgery twice or thrice for vertebroplasty. And you see there's a cement which is lying in the epidural space. Patient is having problem, and you can't really, before he goes for another surgery fixation. And we have to do a spinal cord implant, and we're trying a trial for the same is done for the neuromodulation. Sometimes there's a root irritation, and you can do a DRG stimulation, and it really helps these patients. So these are few things which are doable, if surgery is not on for one or the other reason. And same as I do, these are one of my innovation. I put a fine KVR first, and over the KVR I put my vertebroplasty needle. There is a reason for that. In the thoracic region, the pedicles are very small, so I don't want to go with a big needle in there and then readjust the needle because the pedicle gets fractured. So putting a KVR and then putting over the KVR, putting a needle is always on, and that's the D5, D6 level. A patient who is a doctor and a good fill in the. He had a cervical disc level also, we did it. Now, another one innovation, which when we had to do a vertebral planar or vertebral fracture, flat fracture, we don't really follow the superior upper quadrant. We just go in line in the fracture line or body and try to do a fill. So there is a change. We don't start from the superior upper quadrant, then it tends to go the lower end plate. So that's to be avoided. Now, there's a patient who was a single level fracture and was left alone for healing, which is okay, very much okay. But over about 2 months and 18 days, he developed 6 level fractures from one single fracture, which was looking quite nice. And and then I did a 6 level fill. This was in 2010, and I presented this case in the World Congress in Miami. Now, when we have to do a multiple level fractures, we don't go from the same side for a reason, because then the needles start fighting over each other and you can't do a nice fill. We try to go alternate if possible, if required, and if feasible. And when you have multiple levels, obviously you have to aspirate marrow before you go and put in a cement there, because marrow gets into the pulmonary circulation, embolizes, and causes complications. That was the reason we were not doing more fractures at one time, which I did 6. The same patient, after a few years, a nice stability of the spinal sagittal segment. That's where in some patients the vertebroplasty outweighs the conservative treatment, which is very much on. But never ever stop the osteoporosis treatment. It has to carry on because the patient tends to have another fracture otherwise. I have done another thing is, which we have so many more cements which are there for radioplastic. What I do in my case is, when I'm making a cement on my cold saline, I put in a Omnipac dye, which we use for all this dye check. So that Omnipac dye is good visualization. I've got cement for the last 15 years. None of them have broken till date. And the stability is even as good as that. And cement is almost black. And you see the first drop of cement going out of the way, and or into the vessel or anywhere else. And I'm using 2 ml of syringes. I'm not using 2 ml syringes at one time. I take 1 or 2 ml cement and then inject inside, because you're not going to overfill any time, because which causes more accident than the underfill. And second is a 25 rupees syringe, or this saves 25,000 rupees on the part of the patient, because patients are normally poor. Ever be careful when you're retracting, taking the needle out. Sometimes there is a cement nail which is left back. So one has to break the cement nail here before you take the needle out, because these are few accidents. They do happen, especially when you're complacent and too confident about things and you're easy about it. It does happen then only. Even in my hand, sometimes it happens once in a time. When you're too easy, too happy about a good job, and suddenly you are left with something to remove, which is very difficult to remove from the soft tissue. Now, this is the extension. I use the extension and electroction in some patients where you want a good fill. And that's really, decrease the load on the anterior column, which you have to fill. Now, some patients who have been done a good job, but still the patient is painful in here. And this was the one which was there requiring a fill. So I had put in a Kyphon balloon. This is dorsal level, by the way, and I put in a cement. Patient became pain-free. Now, sometimes there would be situation. You have done a good job, but there is a segmental loading and the facial arthropathy because of the mechanical destabilization. So you have to do that facetal work sometime. And it's some people say facetal work, some people do rami communicantis, and some people done intravent. I'll show you. And they say that is good enough. You don't have to do cementing, because some people are against cementing these days. But yes, if it is osteoporotic setting, it's always better to do it. And this is rami communicantis. If you just do the rami communicantis work, it does help in discogenic pain. Let me tell you, anterior discal pain is a visceral or some sympathetic pain. It's not the somatic pain. So sometimes doing that work helps in these patients. In a malignant setting, yes, cement is always on. But there's a latest study which says if you do a targeted radiofrequency ablation of the tumor cells and the cementing thereafter, it gives the best result of the pain relief beyond the RT, or along with the RT for that matter. And this is very new work, I think probably is in making, and that is called intravent. The sinovertebral work nerve which is going onto the unplates, and they are ablating it at the sinovertebral foramina. And this is the new work which I'm just sharing with you. Although I've been doing this for ages in the malignant setting, I used to take my plain RF needle and do my ablations there. This is what the intravent machine has come in, and they put in the same thing like kyphoplasty or vertebroplasty. Put a needle in there. There's angled, burr which is there, goes in there, and then you put your radiofrequency probe there, and then you burn out the sinovertebral nerve, and the pain is taken care of. That is for vertebrogenic pain, by the way. And that is common with even with Modic changes. Modic 1 changes, some people have it. And this is the new treatment which has come in. And this is how it is done. You have the needle going in and the probe is gone in. Radiofrequency probe is called Intracept. Look at the kit there. This is all vertebroplastic kit with the angled approaches, like you can call burr. And then you have the radiofrequency probe, which is there, which is thermogenic. And then the pain is taken care of. Can be done at any level or multiple level for that matter. Well, when the cord is in danger, now this is a osteoporotic fracture, or the cord is already compressed, there's some myelomalacia coming in, or it's a malignant fracture which is there. Patient is having a danger of a further retropulsion and the cord compression. And that is what you're doing. This is my own device, the NJ balloon and safety balloon, which I put in. This is my vertebroplasty area, and I had to put it a segment or two below from the transforaminal area, like we do epidural endoscopy, transforaminal endoscopy. I put my balloon in there, shove it up there, right next to the posterior cortex, and this lies next to the posterior cortex of the vertebral where the fracture is. When I'm doing my anterior work, I'm always looking at the vertebral area, or sorry, epidural space, whether there is any compromise or cord compression coming in. And by the way, this is 6 mm balloon. When I take it out, my patient is happy back home. There's never ever going to be compression. And I can inflate safely, because if you don't have this, when you're inflating, you don't know which segment is getting retropulsed. And there's a very big danger. That is why many patients were avoiding this procedure. And this is how it has been done. One level I'm doing cementing, other level my balloon is inflated. It is not inflated in one go, it is transiently inflated between these two balloons. And this is the end of the procedure. Cementing and a straight balloon, take it out, there's no filling defect. And a myelogram, sometime I check myelogram, is very, very rewarding and very kind of satisfying. Now, this is a burst fracture. I did it 2005, and burst fracture, multi-polytrauma setting patient. And then I did a cementing on this patient. This is the fracture void. You can see the retropulse fragment, and it is cementing. Everything was in one place, and patient was sitting very next day. This is 2006. This is this year only, just a month back. A doctor, professor's sister, she had a fracture and a bad crooked spine, you can say, crooked spine. This is the fracture retropulsing, and this is another level, you can say, retropulsing. And she had a scoliotic spine and bad spine. And I did a cementing on this patient with the same technique procedure. Although my balloon didn't go up in there, my guide wire, which was quite reassuring, and I could manage it. This is another patient, vertebroplasty, not to be taken up, but she's 86 age lady. These are comorbidities which doesn't allow the surgery to be done, but they're in pain. So that's where we can really help those patients. What I did is I put in my needle in with the safety balloon. I inflated this thing, anterior vertebral column, and did a good feeling of the anterior vertebral column, and patients walking back the very same day rather. And this is, we say, the kissing disc now. And as we say, kissing spine is a kissing disc. And I could really reform the vertebral, this is called a vertebral reconstruction instead of augmentation. You see, it's all zero. And we can really have weight bearing structure. Look at the sagittal balance, which has really been created. We have anti-column elevation. So this could make the possibility of these kind of dirty patients. And we can really, with the epidural safety balloon, we can really make this procedures possible. I presented in World Congress in Jeju Island. This is the epidural safety balloon, epidural neuroplasty, foraminoplasty. But I'm extending this into the vertebral fractures also. And many of these patients can be taken care with these patients. And by the way, they are comorbid patients. They really can't really go for the surgical reasons, one or the other, patient reason or the surgeon reason or anesthetist reason. But yes, you can very well do this procedure along with the safety balloon. This is one of a few slides only. The sacral fractures, you put a needle there in the fluoro room, take the patient to the CT room with the needles on, and put the cement and filling there, because putting needle in the CT is a very difficult job. Same patient which I showed you, doctor, he had a D5-6 level gone. I put in a needle, epidural needle, some cementing, and that's done job. Last patient, and this is C2 body. C2 body involvement is there, transoral, putting needle in there, and this epidural needle, by the way, and just putting some cement is on. So vertebral augmentation in difficult situations like burst fracture, vertebral plana, and along with the this malignant fracture or something, or multiple level fractures, you can do it. You can do it safely, effectively, and with the good results oriented. And I always say the teaching is learning. My teachers are sitting here. So I always say they are learning most out of this conference along with me. And thanks to my family who is helping me to carry on with all this work what I'm doing. Thank you, my friends. Thank you for giving me time and listening to me. Thank you so much. Thank you, friends. I had few more innovations tomorrow I'll be sharing. That is in the discal part of it. Thank you.
Yes, sir. Thank you so much. Now we are starting with, we are running late, but you're going to finish with the 3 paper sessions. I call upon Dr. Jipin Gopi. Please stick to your time and give us a crisp presentation. Dear doctors who are in the committee, please keep your sheets ready. And you're going to mark in each category from 0 to 5. Yeah. Each category will carry 0 to 5 marks. You need a pen? I'll get it. 2 minutes. 2 minutes. He'll come. It's coming 2 minutes. You just listen to him right now. Yeah, Jipin, let's start with you. Hurry up, please. Yeah. Please set the timer for 6 minutes. Yeah, they know that. They can see.
Good afternoon, everybody. The title of the study is Basic Decompression for Lumbar Canal Stenosis using Unilateral Biportal Spine Endoscopy, the Initial Learning Curve. As we all know, one of the most common indications for spine surgery in elderly population is degenerative lumbar canal stenosis. The current gold standard in the treatment for lumbar canal stenosis, refractory to conservative management, is a facet preserving laminectomy. But for this, a midline lumbar incision has to be made with bilateral dissection of paraspinal muscles to expose the lumbar bony structures. The classical approach involves extensive soft tissue dissection that can lead to fatty degeneration, atrophy, weakness of paraspinal muscles, spinal instability, and can lead to failed back surgery syndrome. To avoid such complications, several minimally invasive techniques has been developed in the recent times, such as tubular and endoscopic spine surgery. Unilateral biportal endoscopy is one of the most recent addition to minimal invasive spine surgery, where the procedure can be done with maximal preservation of natural anatomy. But these advancements require a longer learning curve for inexperienced surgeons. The learning curve is defined as the improvement in surgical procedure performance with increasing experience and training. The study aims to depict the initial learning curve of basic decompression for lumbar canal stenosis using unilateral biportal spine endoscopy. 42 patients with degenerative lumbar canal stenosis treated by UBE decompression were retrospectively reviewed for this study. Inclusion criteria included radicular leg pain, neurological deficit, neurological claudication, all due to moderate to severe lumbar canal stenosis. Exclusion criteria included scoliosis, segmental instability, history of prior lumbar spine surgery. Surgical technique: after induction of general anesthesia, the patient is placed prone with abdomen free over the radiolucent pillow. The skin and surgical field are draped. The spinal level of interest are determined using C-arm guidance and marked on the skin. 2 incisions are made: a larger distal incision for the instrumental portal, a proximal smaller incision for the arthroscope insertion, and continuous saline irrigation. With the help of shaver and RF wand, a small working space is created. The initial target area for decompression is at the spinolamina junction. The ipsilateral lamina is then drilled from its lower margin cranially until the origin of ligamentum flavum and underlying epidural fat are exposed. The ligamentum flavum is separated from the undersurface of the contralateral lamina. Then the undersurface of the contralateral lamina is drilled. The ipsilateral half of the ligamentum flavum is then removed, followed by ipsilateral decompression by drilling the medial margin of the ipsilateral lamina and facet joint, freeing the ipsilateral transversing nerve root. The contralateral half of the ligamentum flavum is then removed, and the lower surface of the contralateral facet joint is decompressed to free the contralateral traversing nerve root. The end point of decompression is free mobilization of the bilateral nerve root, which can be attained by resecting the lamina bone and facet flush to both the pedicle along the medial pedicular line. SPSS 20.0 software was used for statistical analysis along with Chudens t-test and Kyphoplasty test. The learning curve was assessed using the QSUM analysis. Results: male to female ratio was 16:26 with an average age of 65.07 years. All the patients underwent UBE operation successfully with a mean operating time of 115.3 minutes. The operative time showed a downward trend as a whole in the scattered chart. QSUM analysis showed that the curve reached the maximum by 24 cases and then gradually decreased. So the cutoff of the learning curve was decided as 24 cases. According to the cutoff point, the curve was divided into two phases. The initial learning phase, where the Q-sum value was gradually increasing, followed by a late proficiency stage where the Q-sum value was gradually decreasing. On comparing general data between the two stages, there was no significant difference between age, sex, body mass index, pre-op complication, duration of symptoms, and operative level. However, the operative time and post-op hospital stay improved in the second stage. There were 4 cases of complications, including 3 cases of dural tear, 1 case of transient root injury, all of which occurred during the first 24 cases. There was no case of symptomatic epidural hematoma or surgical site infection. As a recent addition to minimally invasive spine surgery, UB technique requires substantial learning period to master the procedure. A minimum of 24 cases is required for an inexperienced surgeon to gain adequate confidence and to perform the procedure with a satisfactory outcome. To conclude, with UBE technique, decompression for lumbar canal stenosis can be performed safely and effectively. It is possible to avoid spinal fusion and maintain segmental stability since the damage to soft tissue and face joint is minimal. A skilled radiographer, trained staff, the right equipments are all crucial components in the initial learning phase. The learning curve can be shortened when a surgeon gains relevant knowledge, understands 3-dimensional anatomy, and has a surgical aptitude along with manual dexterity. Thank you.
Wonderful talk, Jipin. Dr. Om Prakash Singh, please. Stage is yours. Dear judges, you all are going to have a tough time. Please assess fairly. It should not be heavily weighed in the side of UB. No? It should be weighed all equally. Start timer. Reset. Are you ready, Dr. Chip? Are you ready, Dr. OP Singh?
Yes, sir.
Okay, we're restarting a timer right now. Start.
My transition from open to endoscopic spine surgery, I told about my story. I did about neurosurgery training in spine surgery, especially degenerative spine surgery and open microscopic surgery. But I was attracted to minimal invasive spine surgery due to obvious reasons and tried since 2012 tubular system, transforaminal, but not work for me. Poor visualization, complications, especially fear of neural injury, stopped me to go forward. I heard about AV in 2018 and got my training. UV is a semi-tubular liquid-based biportal system. And one port for scope and instrument port. It is clearer vision, bloodless surgical field than air-based tubular system. Advantage of wider view and free movement of instrument as of open surgery was a main attraction for me to go with this system. And I studied 12 patients. I operated for last 1 year, and I present the results. The method of UV surgery was same as already described. Irrigation fluid with normal saline, 3 liter. Height was about 50 to 70 centimeter from the patient back. And I used dual port of urology connector with a stopper for irrigation fluid. Wilson frame and anesthesia was G or epidural, and position, prone position. Incision, medial pedicle line, in AP view. And first I formed the scope instrument port, then 3 centimeters above the scope port. Incision size was 8 to 10 millimeter, and for a instrument port, and 5 to 6 millimeter for a scope port, and triangulation of the scope and instrument at the spinal lamina junction as usual. This is all my setup. Observation and results. Out of 12 patients, 4 were male and 8 were females. The average age of female patient was 37.7 years and male around 50 years. I operated 3 cases of L4-5 PIVD and 8 cases of L5-S1 PIVD and 1 case of L3-4 lumbar canal stenosis. Out of 12 patients, 11 patients improved in pain, that is 91.6, and 1 patient was converted to open. And the complications were mainly incomplete decompression in 1 patient. Dural tear was in 1 patient, and I converted it to open. And hypothermia was initially a major complication for me, and it was difficult to learn how to manage because I was used to make a small draping and then all fluid extravasated it. And in the post-op, I have to spend 1 hour, half to 1 hour to managing the patient for hypothermia. And that I learned that by adhesive dressing and adhesive packaging. And then I came out. Scope damage was, my 2 scopes were damaged initially because I was new to endoscopy and I just came from open to endoscopic. So I have no experience about the scope and damage. Damage with drill or RF. Bleeding control was main issue, and there is 4 arteries supplying this area: interarticular artery, superior articular artery, inferior articular artery, and radicular artery. All branches of segmental artery. Anatomy must be understood. Use of bone wax, RF console, IPGel, surgical, closing and opening the output for a few minutes. These were all used for stopping the bleeding. Turbulence of drill was a major problem during initial working, and all the view was obscured. So I used concomitant suction. And in the conclusion, UB offers a vision as clear as microscope. So I had not very much difficulty in learning it. Same instrument, same anatomy of interlaminar approach as open, and freedom of movement of instrument. I found it easier to learn, as it is told that to learn transforaminal or PSLD, you should do about 100 cases, where you will be learning curve is shallow, and 30 cases for non-endoscopic surgeon, 15 for endoscopic surgeon. That I found it is almost satisfactory for me to learn easier. And fluid inflow outflow management is crucial, I think, and hypothermia must be avoided with wide draping with adhesives. Few videos. This is my present cases.
Your take-home message, doctor. Replaying. Slide is replaying. Just help him, please. Go to the next slide, please, doctor, and conclude your talk. Thank you. Thank you so much, doctor. I think I would give you bonus marks for your honesty. You've spoken about your complications. You've spoken genuinely about your learning curve. Thank you very much. Excellent. Next young man we have is Dr. Kiran Jaiswal. He's not young, but he's young at heart. Good evening. Ready to start? Play your thing, please. Then we'll start the timer. Play mode. Yes. Timer starts now. Just stop the timer. 1 minute, please. Put the mic on for him. Right.
Hello, am I audible? Yeah.
Yeah. Reset the timer, please. Start.
Good evening, dignitaries, juries, Dr. Malcolm Pastanji, and the Third World Congress. I'm Dr. Kiran Jaiswal. I was anesthesiologist and then I did orthopedic surgery. I was doing endoscopic spine surgery, rather it's a transforaminal and interlaminar since 2013 onwards. Today I'm presenting my initial 20 cases for percutaneous lumbar transforaminal or transcambine interbody fusion. So that is what spine surgery is. The third most common operative area, is growing faster, and it's from eye and heart, it's the third faster growing, where the costs are high and complications are frequent. Even when outcomes are good, period of the instability after surgery and disability and is substantial. The future of the spinal surgery is minimal invasive, that what we are going on and what we are seeing today. Since last 20 years, the magnitude of spinal surgical procedure has been increasing. However, we see the reversal trend that the spinal surgical procedures are likely to become increasingly less invasive. Endoscopic spine procedure will be of value for those recommend alternative to the standard surgical operations. And the rest of the other group of specialists, those who perform, these are the procedures. I am one of them. My introduction is like kind of most common basic surgery for the spine degenerative diseases. This, what I included is non-traumatic degenerative patients. And ultimately, percutaneous endoscopic spine surgical not only offers decompression, but also facilitates interbody fusion via cage placement of the same entry point, transcambine, portal via posterior percutaneous screw fixation, and the fenestrated if at all required, because the majority of the patients are comorbid and old age, and either with a kind of low bone mass. So we can use fenestrated and augment it. So my initial 20 cases, long-term outcome remains same, age of surgical, MIS, or endoscopic. So patients is ranging from 40 to 85. Primary inclusion is instability. With the strict asepsis and under prone position with the bolster over the chest and the pelvis to maintain lordosis, with image guided and video assisted under local anesthesia and sensory block, not under general anesthesia. Now, via same introducing needle, at defined level, we give sensory block, and under monitor anesthesia care, transforaminal endoscopic decompression and discectomy has been performed. And of this disease segment, preparation of the end plate via using bendable kind of curates, annular cutters, and garrisons and disc rongers. It's facilitated via 3.6 to 4.3 working channel. First, we kept percutaneous screw, and then we put adequate size spacer after distracting. Once we prepare the bed for the cage via transcambine route only. And finally, all check, we do fixation and bone substitute if at all require. The final entry point sutured with the single layer after surgery without drain placement, tight dressing will be done, and 7th and the 12th day suture removed afterwards. Patients were mobilized with the help of the lumbar braces for own routine daily activity immediately after and advise physio rehab program from first day. They can perform. All patients were discharged within 24 hours. So results of the initial 2 cases has neuropraxia because of that distraction, and that was not available sleeve dilators to introduce the case. And with the help of Dr. Malcolm Pastanji, we got it, and now that the issue has been overcome. So out of this, one recovered and another is still into having foot drop. Initial one had small case placement and rest of the other uneventful. My conclusion is like less hospital stay, early mobilization using natural and anatomical corridor. So there is no epidural scar or even no muscle and tissues. That saves even time. Under sensory block and local, that's why no neuro monitoring required. It's a facetal sparing surgery, and percutaneous transferical cannulated screw allows even vertebral augmentation also. Total blood loss not more than 100 ml in all cases. No need to keep drain in all cases. No catheterization. Now dural tear in all cases up till now into this, because we are not going to retract the dura or nerve root into this transcamping approach. So there are list, or here we don't have encounter any of the dural except that neuropraxic in initial cases. No forceful placement of the case, because that the same way we introduce the dilator and distract it. So without forceful, we can introduce case inside of adequate size. Bone substitute we have used and return to the daily activity for the patients. One case here we can see, right? She is almost 75-year-old age, obese. Second case, this is scoliotic. We can see the coronal and sagittal correction very nicely over here. This, and we can see that how we have used that transcamping portals for the disc removal. The same portal has been used for the case placement. Thank you.
Fantastic. Thank you. Thank you so much. Excellent talk. Next speaker, Dr. Malik Lingalia, please be ready.
Good evening, everyone.
1 minute.
My
1 minute. Start your presentation. Yeah.
Yes, sir.
Ready?
Yes, sir.
Yeah. Your talk starts now.
Yes, sir. So my talk is on transforaminal percutaneous lumbar discectomy from the superior migrated disc in hidden zone of McNabb. The lateral lumbar spinal canal is subdivided into the 3 parts: the lateral recess, the pedicle foraminal part, and the extraforaminal far lateral zone. Within these regions lies the McNabb's hidden zone, which is the area known for its difficult surgical exposure. In 10% of patients with these lumbar disc herniations, there is fragment migrated cranially in McNabb's hidden zone. Anatomically, this McNabb's hidden zone is an area which is bordered laterally by the pedicle, by the dorsal part of vertebral body ventrally, and the covered dorsally by the pars intraarticularis of hemilamina of cranial vertebra. Now, the difficulty with the surgical exploration of this region, while the traditional interlaminar route is only possible after at least partial removal of ipsilateral hemilamina or even hemilaminectomy, and it may additionally require the partial or complete facetectomy. So, to leverage the manipulation of the fragment underneath and proximal to the axilla, the surgeon inadvertently tends to go laterally, and which may cause fracture of the inferior articular process. The extended laminectomy as a means to approach the hidden zone has therefore some disadvantages, and since the associated removal of biomechanically important bony structures has been suggested to increase the risk of secondary segmental instability and may subsequently necessitate the fusion surgery. In my study, we have aimed for the transforaminal endoscopic discectomy for the superiorly migrated disc in the hidden zone of McNabb, and we have objectives to the efficacy, advantages, and the disadvantage of this method. The patients with the superior migrated lumbar disc herniation treated by this method for the duration of 2 years were evaluated for at least 12 months with the back pain as well as radicular pain symptoms with the visual analog score and the Oswestry disability index for the functional improvement as well as the modified McNabb criteria for the patient satisfactory response. The standard instruments we have used with the plasma frequency ablator, the flexible grasper, and the hook. The inclusion criteria was the radiologically confirmed the superior migrated disc at the single number level, and the patients were included after a trial of conservative management for at least 3 months. All the patients which are having more than one level of lumbar disc herniation or as well as some facetal arthropathy or other neurological disorders were excluded from the study. Our results were quite satisfactory. We have included 12 patients, out of them 4 were women and 8 were men with the mean age of about 48 years. And the VAS analog score for the back pain was 9 out of 10. And for the leg pain was 8 out of 10 before operation. And it came down to 3 of 10 and 1 of 10 at the post-operative periods. The average Oswestry disability scores were also reduced from 92 to 15.30 at post-operative 1 month, and post-operative at 12 months, it was significantly reduced to 9. The VAS score significantly improved, and the total duration of time we have took for the surgery was about 60 to 90 minutes in between. These are some images with the highlighted circle of the area, which is the LDH, and these are the lumbar X-ray of the case. The CM image which shows the use of the hook, as well as at the same time the clip shows the use of the hook which was done to migrate the fragment, and the image shows the removal of the disc. Our discussion part was this: that compared with the open surgery, the percutaneous transforaminal approach for this has the advantage of it has a minimal invasive with a little impact on the stability of the spine, with a rapid recovery, less than 50 ml of blood loss, and patient can be mobilized as early as possible on the same day of operative management. Therefore, this fragment can be easily detected and removed without doing any laminectomy and without sacrificing any important vital bone structures. The end result is the patient has retained a functional spinal unit and capable of carrying all the future activities as soon as possible. With more than 96% success, the LDH, including severely difficult as well as extremely difficult as per the Leeds radiological classification, are accessible by this method, and this can be considered as another alternative modalities in the treatment of all kinds of disc herniations. No damage to any bone and vital structures, so the functional has given us the good advantages over the patient.
Dr. Malik for a wonderful talk. Next, we have Dr. Clivio D'Souza. You ready?
Yes, sir.
Your timer starts now.
Good evening to one and all. My topic is our experience of the functional outcome of unilateral biportal endoscopic ligamentum flavum preserving discectomy. So with a 30% yearly point prevalence, low back discomfort is one of the most common signs of spinal abnormalities. It has been identified as one of the leading causes of worker compensation in public health spending worldwide. It is one of the foremost debilitating conditions, low back pain affects roughly 70 to 80% of people at some point of time in their lives. Lumbar disc prolapse is one of the major reasons of low back pain that causes severe morbidity around the world, affecting primarily the working class young population. Degeneration of the intervertebral disc is an abnormal cell-mediated response to progressive structural failure. This degeneration affects the entire body. The lumbar spine is the most affected, followed by the cervical and thoracic spine. Nutritional inadequacy, mechanical load bearing, injury, trauma, and hereditary variables all play a role in degeneration etiology. Prolapse of the intervertebral disc into the intervertebral foramina, particularly at the L4, L5, and L5S1 levels, is caused by degeneration caused by a variety of reasons. Because the success of surgery is dependent on a number of criteria, including careful patient selection and a thorough clinical history, a physical examination accompanied by pertinent radiological studies can assist distinguish disc prolapse from other causes of low back pain and sciatica. For more than 20 years, patients have been treated successfully by minimally invasive spine procedures. These spine surgeries have swiftly developed from mini open to tubular or percutaneous endoscopic techniques as surgical instruments and endoscopic technology have advanced. Aside from the potential advantages of the minimal invasive approach, that is less local pain, smaller wounds, less post-operative wound pain, and less duration of hospital stays, there are studies which have shown that the posterior column, including the facet joint capsule and interspinous ligaments, play a major role in maintaining spinal stability. The technique of unilateral biportal endoscopy is a full endoscopic method which is done percutaneously. The procedure is initiated by taking two small surgical incisions on either side of the spinous process. This procedure does not rely on the working tube or the working channel to function. We conducted this study to describe the UV discectomy technique for lumbar herniated disc with the aim on how to perform these procedures safely while also preserving the structures like the facet joints through the posterior interlaminar approach, and the efficacy of this technique was assessed by the clinical outcomes. So this was a retrospective study conducted between July 2019 to 2021. That is a 2-year study with 41 was the total number of patients. So patients were included according to the inclusion and exclusion criteria, with the inclusion criteria being lower back pain with neurological impairment and persistent radicular leg pain that has been resistant to conservative treatment for at least 6 months due to a moderate to severe prolapsed disc as evidenced by an MRI. Exclusion criteria was spondylolisthesis or degenerative scoliosis, lumbar stenosis, inability of the spinal segment, which was defined as lateral bending on upright anteroposterior radiograph or translation of more than 4 millimeters or 10% of angulation. So there were 22 females and 19 males, and a total of 54 levels of discectomy were done. 1 level discectomy was done in 30 patients, while 2 level discectomy was done in 12 patients. So coming to the discectomy, which was carried out in the order of the ipsilateral lamina was burred from the lower margin cranially until the underlying epidural fat and origin of the ligamentum flavum was exposed. The main part in our procedure was the fifth point, which in an L-shaped manner, we detach the lateral attachment of the flavum ipsilaterally. So it should be noted that preservation of the ligamentum flavum is a must as it protects the underlying neural tissue. Using a semitubular retractor, we medially displaced gently the neural element depending on the position of the herniation, that is axillary or lateral, and then the herniated disc was approached. Epidural fat, axillary vessels may require plasma probe application to control bleeding and exposing the disc. Using an Indian knife, that is a stab knife, specifically designed for UB surgery, we entered the intervertebral disc. We started with subligamentous resection of the herniated fragment before processing of deeper fragment extraction if loose fragment was seen. We proceeded as a normal discectomy, followed by a repositioning of the stripped flavum. So the visual analog score was used to assess back pain and lower leg symptoms. The Oswestry Disability Index was used to assess degree of disability, and modified McNabb's criteria was used to assess overall outcomes of treatment. Patients were examined by this functional evaluation before surgery and at the end of the treatment. So this is a preoperative sagittal and axial MRI image in a 34-year-old male who is one of our patients who complained with left radicular pain showing an L4, L5 disc herniation on the left side. This was an endoscopic image showing the relaxation of the L5 nerve root after the decompression. So coming to the results, duration of follow-up in our study was 6 months. Per level decompression, the surgery took 89 minutes. Amount of blood loss during the procedure was minimal. On the same post-operative day, most of the patients were ambulated and discharged using a brace. Following the procedure, there was significant improvement. At the final follow-up, leg pain, VAS score improved from 7.2 to 0.8. The back pain VAS score improved from 4.2 to 1.1. The Oswestry Disability Index went from 54.5 to 14.5. And the ultimate outcome was excellent in 24 patients, good in 15, fair in 2, and poor in 0. So the most important aspects of UB are familiarity with hydrostatic pressure control and hemostasis scaled in a limited space using continuous normal saline irrigation. In UB, rate of infection is much lower than in open surgery. Although a dural tear can occur as it did in our study with one patient, most tears are small and conservative treatment is sufficient, or suturing repair with Proline can be done as in our study. It is feasible to repair the dura under the endoscope. Most importantly, repositioning the ligamentum flavum serves as an excellent protection for the underlying neural tissue. Coming to the conclusion, UB discectomy approach for lumbar disc herniation is a minimally invasive procedure that is both safe and successful. There is no soft tissue degradation or facet joint destruction. As a result, it is possible to avoid spinal fusion while maintaining segmental mobility and stability. Furthermore, compared to other minimal invasive decompression approaches, the learning curve is less steep. Thank you.
Thank you. Thank you. We now have Dr. Kiran Kumar CK. Are you ready, sir? Dr. Kiran Kumar CK. Okay, it's a no-show. I think we'll go ahead with Dr. Jaydeep Ghosh. We now have our 7th contestant, Dr. Kiran Kumar CK. 6th one. He has not come, I think. No problem.
Okay. Good evening. I'm Dr. Jaydeep Ghosh. So I'll be talking, this is my last presentation, the last presentation of the day. And I'll be talking about scoliosis. So you have been all talking about fusion, etc., about decompression, but I think I'm the odd man out. So the problem with scoliosis surgery is the issues are, it is costly, it is long, it bleeds a lot, requires massive blood transfusion, and it is performed preferably in tertiary care centers. So we tried to explore minimally invasive scoliosis surgery with modifications to reduce their cost. So this is one case. This is the bending film. So what are the innovations that we did? We used 3 skin portals, one at the top of the fixation, one at the middle, and one at the caudal end. So we positioned the patient, we marked, then we did a midline incision, we did bilateral exposure, and through the portals, we placed pedicle screws. Now, these pedicle screws were the normal reduction screws used in listhesis surgeries. It was not cannulated pedicle screws. So herein we place it, and since they are the normal routine pedicle screws, and these are not cannulated, they are very cheap. So we use the simultaneous double rod technique. We place 2 rods and then use the reduction screws. We place the 2 rods in a normal alignment and then use the reduction screws to reduce the spine to the rod, and some amount of rotation and segmental compression distraction in situ bending was used. These rods were connected with 2 cross connectors so as to provide torsional stability. So in that case, we could not do any Pontes osteotomy. And the fusion in the non-exposed area that was skipped was encouraged by facet burning and burring. We use cautery, we use burr, we use the C-arm to locate the facet joint, and then we burred it out. And then bone marrow was harvested from the posterior iliac crest and mixed with artificial bone graft and used to ensure the fusion. So this mix was tunneled submuscularly just above the bones, above the facet joints. And this is the final result. So if you see, the operating time was 4 hours. The blood loss was about 200 ml. The pain scores was almost 48 hours post-hour VAS score. The blood transfusion 1 unit Paxil was used. So what were the intraoperative technical difficulties and perioperative complications? The intraoperative difficulty was inadequate exposure because we have just 3 portals. And in case we need to place screws in areas other than those portals, it's difficult because of the size of the portals. Because of you have to pull the skin a lot, there is problems in the skin edges. The skin edges get necrotic, and soft tissue damage may be incurred due to excessive traction. And you don't have a global view of the scoliosis. Neither you can correct the you can correct the coronal plane, but it's difficult to correct the sagittal plane completely. So no global view of the deformity is achieved. And there was no perioperative complication, no postoperative neurological deterioration. This was not done under neural monitoring because that was not available. There was postoperatively, there was no implant failure. There was the implant was prominent at the cranial end of the construct. So the advantage being less bleeding, can be operated in less equipped hospital, does not require massive blood transfusion, leads to less postoperative pain, hence early recovery, preservation of spinous process helps in reattachment of the paraspinal muscles, and the spinous process also decreases the prominences of the spinal implants. Long term, we don't know what about the fusion rates, the implant failure rates. So it's been around 1.5 years we have done the case. Thank you.
Thank you. Wonderful, informative talk, and it is all about MIS. So it is, you are not a duck out of water, sir. You are in the water. No, don't count. If they marked it, we'll do the counting for it. Then. Yeah, okay. But we'll be declaring the results tomorrow, sir. Just your signatures, please. Huh?